buscando. Me dicen Marisol, que es súper bueno. Este té, este té.
Sí,
La cosa de mirar también afuera, más afuera. Sí, estos son europeos.
Lluvia hoy día. Hace fuerte. Fuerte es muy bueno.
Okay, I think we're going to get started. Can you hear me? Can you hear me okay? Yeah?
¿Qué? ¿Lo van a cortar? ¿Lo van a cortar? ¿Lo van a cortar?
ya los latinoamericanos se organizan. Te sientes en casa con el rey de Ana.
15 minutes both together, no?
Before was it, now we cut for the house.
Okay, so that's what you did?
Yeah.
Okay. Okay, so I think we're going to get started. Can you hear me? You can hear me okay in the back, right? We want to keep this informal, and so we're going to try not to use a microphone. There's a microphone here for our webcast, which should pick everything up. But so I'm delighted on behalf of the Dorset School of Public Health and the Urban Health Collaborative to welcome you all to this event. Buenos días. Bon dia. As an Argentinian, I'm always scared to speak Portuguese because I think I'm going to get it wrong. Brazilians speak much better Spanish than the other way around. But so I'm delighted to welcome you to this sort of pre-event of our second Urban Health Symposium, which will be which you all will be joining us for tomorrow and the day after tomorrow. This is a very special event for us that we're very excited about, and we're thrilled to have such a terrific set of speakers, both today and tomorrow and Friday. And one of the themes, well, the theme actually of this year, as you saw in our program, is this idea of linking local to global, which is a very important concept for us at the Urban Health Collaborative as well. And for a couple of reasons. One is because we really see, in order to understand what's going on in terms of health in a city, you need to understand that city, but you also need to understand what's happening in other cities all over the world, because it's all related, right? And the other reason is because we really feel it's so important for us to share and learn across cities, because cities are doing all sorts of things, and we can learn from each other in terms of what works or under what conditions things work. And so this is another area that we're very interested in here at the Urban Health Collaborative, both across cities in the United States, but also across cities more broadly. And of course, this is very tightly linked to our participation in the Network for Urban Health in Latin America and the Caribbean, which is co-sponsoring this project, and also the Salurval project, the Salud Urbana in America Latina, Urban Health in Latin America project, sponsored by the Wellcome Trust that many of our speakers are connected to in some way as well, which is also sponsoring this event. So we thought, given that we had such terrific international speakers, we thought we couldn't miss the opportunity to do a pre-event where we brought folks together and had perhaps a little more time and more in-depth discussions about global urban health. So I want to thank all of the international folks for traveling very long distances to be with us. So we're really happy that you were able to join us. And also our local team here, Claire, Serafina, Katie, Amy, Ashley, and many others that we'll thank over and over again because they did such a terrific job pulling this together. Adriana. So we hope that the idea for today is for this to be informal. So we've organized it in two panels. The first panel is really focused on this idea of policy relevant research. And so we'll have a series of speakers presenting briefly some ideas on or some of their work, and then we have Jonathan Pirtle, who's a faculty member here who is U.S. focused, but along this theme of local, global, he's going to make some reflections based on what he hears, and then we'll have some, hopefully, a little bit of time for discussion. And then the second panel will be on training, how issues, reflections on what we need to do to train future global urban health leaders. So I'm briefly going to start us off just introducing the first panel, and then we'll, each of you will just come up, since this is an informal. We have a timekeeper who's going to help us keep on track. Anna, she's reluctant, but
Because of past experience.
She's an expert.
So we're going to start out, and I'm not going to go into detail on the introductions. You have a little more information in the program today, and more in the program tomorrow as well. So I think our first speaker will be Olga Lucia Sarmiento, who is director of the EPIANDES program. Is that?
Yeah.
And of associate professor, you're full professor
Yeah, I know.
now already, right? Full professor at the School of Medicine at the Universidad de los Andes. I'll introduce everyone, and then our next speaker will be Guta Friesche. Friesche, did I say it right?
Friesche, yeah.
Friesche. I've known Guta for a long time, but it's always just Guta. I never say the last name. Who is a researcher and deputy coordinator at the Observatory for Urban Health in Belo Horizonte. Valeska Cayafa, who's director of the Observatory for Urban Health in Belo Horizonte. Alex Quitzberg, who is a research faculty here at the Urban Health Collaborative, who's joined us recently. Nelson Bouveia, who is associate professor in the Department of Preventive Medicine in Sao Paulo. Ricardo Jordan, who is here right now. Ricardo is coordinator for the urban management program at the United Nations Economic Commission for Latin America and the Caribbean. And then last but not least, Jonathan Pirtle, as I mentioned, who is an assistant professor in health management and policy and focuses on policy issues and sort of reflecting on how policy information gets translated to actual policymakers. So with that, we'll get started with Olga Lucia.
Thank you, Anna. Thank you for all the organization of this event. It's actually an honor to be here.
Past the slide, I should have given you that, but I don't know what I did with it. Oh, there it is,
yes.
okay.
So today I'm going to present some of the experiences that we have from a program in Latin America. And the title that I included for this presentation is Reclaiming the Streets for People. And these are insights of the Recreo Vías from Latin America, which are these programs that you see here in these pictures. So for those of you who don't know what this program is, the Ciclovia program is a multi-sectorial program in which streets are closed to cars and buses, and they are open on a Sunday and on holidays for individuals to do leisure activities, mainly like biking, walking, rollerblading, and you see the difference between a weekday and a Sunday. This is in the case of Bogota. So what I'm going to present today is first a little bit of the Ciclovia programs in the world and in Latin America, some of the evidence that we have of these programs for physical activity promotion, the characteristics of the programs in Latin America through a quantitative and a qualitative study that we conducted, and how we use that information for a quality criteria that we call Vicis de Calidad Mejores Prácticas, and then I will finish with some lessons learned and policy implications. So this map here are the programs that we have documented in the world that are similar to the Ciclovías. So we have documented at least 496 cities in 27 countries from all the continents that have programs that at least happen 2 times per year or per month. And you see that the highest concentration is here in the Americas. But also within the Americas, the highest concentration and the programs that are more regular, 93% of those programs are in Latin America. And we see that the expansion has happened in this century, where you see here this inflection point and this increment of programs. Most of them are in Latin America, but we see an important expansion here in the US and in Canada. So now I'm going to show you a little bit of the evidence that we have of these programs related to physical activity promotion and healthy behaviors. So in this graph, you see the prevalence of meeting physical activity guidelines, 150 minutes per week among adults. Most of the evidence comes from program in the US. And what we see here is that these prevalence estimates are significantly higher to what we see on those prevalence estimates from their respective cities. So we see that it could be that these programs are promoting physical activity. So we have conducted several studies, mostly intercept surveys and household surveys, to assess to what extent in the city of Bogota, those individuals who are users, both irregular and regular users, are more likely to meet recommendations. And regardless of the dimension, if it's leisure or walking for transport or biking for transport, what we see consistently in the city of Bogota is that users of these programs are more likely to meet recommendations. And we see that for men, for women, for children, for older adults. So in order to better understand these programs, but in the context of Latin America, we conducted 2 studies to describe the characteristics of the Ciclovia Recreativa programs in 7 countries in Latin America. And we also conducted 5 case studies to assess a little bit more the policy processes and to identify factors that could be associated with the sustainability of these programs. And based on those studies, we developed a quality criteria for those programs. So the study basically is, we use a mixed methods approach, a quantitative and qualitative methods that were conducted given the same priority for both methodologies. So for the sampling for this study, we use first the network that we have in our region, the network of ciclovias in the Americas, which has registered 374 programs in 16 countries in Latin America. We sent an online questionnaire to all the coordinators of the programs, and we received responses with the indicators that we needed from 67 programs in 7 countries. And we also selected 5 programs for the case study to assess the policy processes and those factors related with sustainability. And those are programs that differ on funding and organization schemes. 2 programs from Mexico, 1 from Chile, the other one from Colombia, another one from Ecuador. So in order to develop our survey and all the characteristics that we needed for these surveys, we did an expert consultation in 2011 and 2014, and we also conducted a systematic search of the existing programs. Basically, a Google search, because not many, there's not many publications for the cases in Latin America. And we, based on our expert consultation, came up with these dimensions of the programs: the length of the circuit, the day close, the duration, access and attractiveness of these programs, social inclusion, users, number of users, services, and also indicators related to safety. And we also developed criteria for good practice, mainly based on evaluation of these programs, the services that they provide, and the organization. And we also have 8 typologies based on the combination of factors that were determined by our experts as key factors, which include the frequency, the urban scale of these programs, and the length. So for our policy processes and the sustainability analysis of these 5 cases, we use semi-structured interviews with coordinators of the programs, but we also did important documentations of policy documents and press releases. And for this, we use this conceptual framework for this analysis, the conceptual framework from Shediak, Riscal, and Boone, who proposes factors in 3 settings. The settings are the program, the organization, and the external setting. And we also adapted the shredded factors for analysis of sustainability, which include flexibility of the program, having champions for these programs, compatibility between the organization's mission and the procedures in these programs, the perceived benefits to users, and the community support. So for the purpose of this analysis, sustainability was defined as the set of processes that allow for the continued delivery of the program's activities and policies, and specifically for the case of Ciclovia, we consider that the program was sustainable if the program continued meeting the program's definition and main activities since the inauguration of the program. And we also included a concept of scaling up within the program that was related to increment in the coverage, scope, and range of activities. And we recognize for this analysis that sustainability and implementation are concomitant processes, and as we know with these programs, especially in Latin America, sustainability is not given or secure. So we also took into consideration this for our case analysis. So now we had the quantitative characteristics and we had the case studies. So based on that information, we also did an efficiency and a multi-criteria evaluation model based on data and development analysis. So for those who are not very familiar with this methodology, DA is a non-parametric approach that evaluates the relative efficiency of decision-making units. And in this case, these are the ciclovias. And the nice thing of DA, specifically for the Latin American context, is that we are comparing programs that are relatively similar. So we don't give an advantage to big, larger programs versus the smaller programs. And also the results of that evaluation is very dynamic, which allows us to compare in different years what's going on with the program. So in this graph, for instance, you see here the efficiency frontier that we get from DEA, and we have program A, D, and E that are efficient, but we have B and C that are not efficient, but that could have a benchmark. D could be a benchmark for B, so the programs could learn from other programs to see to what extent changing some factors could improve the efficiency. So let's see some of the results from this analysis. So here I'm going to present first a few characteristics of the program. We see an important variability on many of the factors of these ciclovias. So we have programs as small with just 1 kilometer, or we have the larger program, which is the one in Bogota with 113 kilometers. But 73% of the programs have 10 kilometers or less, which is what we see in the US as well. And in terms of participants, we have also high variability. We have small programs with only 40 participants, or we have the case of Bogota with 1.5 million participants, but 81% of the programs have 10,000 participants or less, which is also something that we see here in the cases in the US. Now, in terms of factors that are very important for us in public health for physical activity promotion, we see that most of the programs in Latin America are regular. They happen every week, which is very important for promoting physical activity and meeting weekly recommendations. Some of them are regular within a season, and a few of them are bi-weekly. And in terms of the opportunities for meeting the recommendations, the 150 minutes, we see that more than 95% of these programs have more than 3 hours, more than 150 minutes, which also allows for individuals, adults, to meet weekly recommendations and for the children to meet the daily recommendation. Other factors that are important of these programs are the complementary programs. It's just not only closing a circuit, it's having a lot of programs within the circuit that will allow us to promote physical activity. And we see that regardless of the scale, if it's a neighborhood, it's an urban scale, if it's a small circuit or a big circuit, we see that most of the programs have physical activity classes on the streets, on the parks, or they have complementary programs for sports. And there's an important connectivity with other public spaces that also could help us for promoting physical activity. So you see connection with parks, plazas, touristic places, beaches, depending on the city that we are analyzing. Now, the component of social inclusion. So you know, Latin America is one of the most unequal regions in the world. We see the inequality all over these cities. But in this program, what we see that is very interesting is that the route or the circuit in most of these cities go through low and middle income neighborhoods, which, at least for this program, we see that there's the possibility for different SES groups to navigate and to have opportunities for enjoying the city and to do physical activity. But we also see, which is important, that there are specific programs for family and children, reflecting what we see in Latin America, special events for women and children and adults with disabilities. And in Colombia, we have in municipalities also a program for internally displaced individuals due to the Colombian conflict. So we see that there's some evidence of social inclusion of these programs. So now what happened with our qualitative case analysis? So I'm going to show you here the case of Mexico City and the one in Chile. So all of the case analysis, and based on our sustainability definition, were considered sustainable. These are the set of factors that are associated with sustainability. And in the case of Mexico City, which is a program that started in 2006 and that closes main streets like the Reforma, we see that some of the main factors that are associated with the sustainability include the funding from the government, but also they have diverse sources of funding. They have important champions whose mission is mainly to promote biking, and the other factor that we find very important in this program is the community appropriation. Now let's see the case of Chile, that you see that these notes are a little bit smaller because they have less weight for the sustainability analysis. And it's also a sustainable program, but it's mainly runs with private funds. And the factors that we have found important for the sustainability of Santiago, Chile, is having diverse sources of funding within the private sector mainly. And the other factor that has been very important is the community appropriation as well. So remember that we use this model, this non-parametric model, for ranking the programs and to find the efficiency frontier. So instead of really ranking the programs and present that as a ranking for the programs, we developed the Bikes of Quality Award and the Best Practice Award. And we gave to our programs 3 bikes of quality if they reach the efficiency frontier. For those that didn't reach the efficiency frontier, we provided the specific benchmarks, and we gave recommendations of how to improve the program. And since I know how difficult it is to get data, I gave them 1 bike of quality for at least send me something. So this is the starting point. And I think we all have lived that inside of the bike. And we also have the Best Practices Award, which is more related with having evaluation tools in their programs. So in total, we gave 3 bikes of quality to 21% of the programs. 7.5% received the Golden Street recognition, but most importantly, every program, based on our analysis, receives a full report of potential benchmarks, factors that they could improve, and that was done and presented in our network so they can talk to different programs and improve their programs. So what have we learned so far from some of these analyses? You see that most of the ciclovías are regular in Latin America and are socially inclusive programs, and that's an important thing in a very unequal region like Latin America. But those ciclovías are very heterogeneous, so that's why it's important to have different benchmarks for the program. I don't think the program for Bogota, which is so big, could be the benchmark for a smaller program in other cities. And we see that are innovative, we see that all the time they are changing, and some of the evidence, mostly cross-sectional, shows that they are programs that could help us promoting physical activity. Relating our policy analysis, we identify these factors as main factors, which is the government support, the different sources of funding, and the community appropriation. The last one, very important for the sustainability of the programs, and we developed this quality methodology that also help us for the evaluation of other programs that could go beyond Latin America. Lastly, I just want to end with this picture from our friends in Salurban who visited the Ciclovia program this year, and we had a lot of fun. And we saw Anna dancing and Alex dancing. Thank you.
So I think we can take 1 or 2 very quick questions, and then we're going to move on and try to leave some time at the end. I don't know if anyone has a quick follow-up for Olga Lucia. If not, yes, go ahead, Tolu.
Thanks, that was great. I just had a question. Something you mentioned early on, the graphs that you showed around physical activity and participation, and your thoughts, reflections on what came first, on whether people who are more active participate or whether activity promotes that.
That's a good point, because we don't know if they are active and they are participating, or if they are participating and they become more active. So in new programs, I think, and that's what we've seen in US programs, new programs, that's true. People who are more active are the ones who participate. But in a program like the Bogota program that has a history of 43 years, I don't think that's the case necessarily. Because this program has been part of our lives since we're children. So we had the opportunity to provide the program for an entire generation. So I'm not sure the case of Bogota that's true. Right now we have a study in which we're following regular, irregular, and new users to see to what extent really the program is associated with physical activity promotion.
Okay, I think we're going to move on, and we'll hopefully have some time at the end. So I think Valeska is next.
Good morning, everybody. Thank you very much for inviting us to be here, and we want to share, Ruth and I, we organized this presentation. We're going to explain a little bit about what we have done as an observatory for urban health in Belo Horizonte, and share with you some of our results. As an observatory for urban health, we have done a lot of different view looking at the city in different projects. And the one that we want to present and to focus now is the urban standard in slums, the regeneration studies that we have studied in Belo Horizonte as an opportunity. Belo Horizonte is a city, it's the 6th largest city in Brazil, and it has 2.3 million people, and about 20% live in slum areas. I'm going to show you a little bit more about that, and we are in about 300 kilometers square meter, and our HDI is 81%. We have, as you can see, a lot of coverage in water, garbage, and sewage system. It looks very nice, no? Very, very covered. But we do have a lot of slums and a lot of different vulnerable areas, as they say, the zone for special interests, social interests. So as you can see here, we have several small spots of slums and vulnerable area around the city. And those are, according to the urbanism department, qualified as villas and slums, another precarious areas, and some areas that they call the vulnerable, the social special zone for intervention and social. The interesting part in Belo Horizonte is that we have also a high geological and geotechnical risk, and about 4,000 families where we are living there, which makes, because Belo Horizonte is a very mountain city, so there is some problem relate to the geological place where people live. As we say, God is Brazilian, so we don't have hurricane, earthquake, nothing like that. But we do have some problems related to geological risk. So this was in the beginning of our study. The observatory was founded in 2002, and this was one of the first studies that we've done relate to how we look at urban health and trying to understand the case of Belo Horizonte. So compiling several dissertation theses from our students from the MPH and doctoral, we organized this information on several outcomes, and we put them together using some index, some territorial index that we use, that is being used for the participatory budgeting. This is called the Quality of Life Index, Vulnerability Index. So as you can see here, if you remember that slide about the slums, all those red and black spots are where we have 4, 3, or even 2 overlapping all those outcomes that we use, like, to understand if there is any combination of outcomes that could measure some social, some marker for social events, some marker for health service, and some marker for vectorial disease. So this is our beginning. So thinking about that, years later, it's not easy because it's very difficult to follow this to get the financial part and things like that, and also to make the arrangement, because we've been working in an intersectorial way and trying to come up with in several departments of the city, of the municipality. So we decided to develop this project aiming to assess the impact of urban intervention. This project is named Vila Viva Project, and trying to understand the health impact of those interventions in the Belo Horizonte. I will tell you from where this money comes from. So we decide, and I'm going to present very briefly, and Ruth is going to say to discuss about with us about the homicides. But we decide to look at very similar events, looking at this intervention, trying to understand the inequalities in the city. So it's a natural quasi-experiment study. We use mixed math. We use a lot of different quantitative and qualitative maths. And but the beginning of the design, we try to understand the policy or the intervention itself. So we have a very good relationship with the urbanization department of the city. It's called UBEL, Urbanization of Belo Horizonte. And this institution, this company was created in 1983. In 2005, they started developing this Vila Vila project, and it was sponsored by the Inter-American Development Bank, the National Bank for Economic and Social Development, and a special bank in Brazil called Caixa Econômica Federal. In 2007, this program was assumed by the Growth Acceleration Program, which is called in Brazil the famous PAC, that unfortunately for this next budget it's zero. So I don't know what's going to happen in our country right now. But anyway, at that time, 10 years ago, the PAC proposed a structural intervention seek to integrate settlements, slums, and house complex to the formal city. And this was done for the entire Brazil, but it was assumed by this, the municipality as to the way to sustainability of the Vila Viva project financiation. So, the Vila Viva is very comprehensive intervention regarding the physical, social organization, juridical, legal intervention. And it's based on a very interesting community participatory study that is done before the intervention, together with the population, just to try to understand the needs and the priorities of the population, and combine that with the pilot, the study for the entire municipality. And the idea is to do some environmental and urbanistic recuperation, there's some social development intervention, and land titling in order to get this urban and legal Vila O project. So here we have a lot of urbanistic structure. Some of you have, 3 out of 6, no?
Sí.
This is the yes. So we have this, all those interventions. The environmental requalification. I bet some of you have been there during, we've been visiting this place every time we have opportunity and we have some visitors there. So we decided to do this health impact evaluation, and now we divide that in two phases. Phase one, where we use secondary data. Luckily, we have a very good health data in Belo Horizonte. And so we create this data warehouse from 2002 to 12. And we use different data, not only for the denominators, but also for health data using the unified health system, which is called SUS in Brazil. And so we geocode all those information, and now we present some of the results. The phase two, the household survey, we just finished the first pilot because we have some problem with support, the financial problem, not we, but our sponsors. So I'm gonna go very quickly in some of these outcomes that we've been exploring. Most of them are some dissertation, theses of our students that I myself and Guta, Frisch, and other colleagues that we have been tutoring or advising. So I'm gonna focus on the hospitalization data right now. So we use that's called the hospitalization authorization system from the SUS, where 7% of the population is reported in the system when there is a need for hospitalization. Because this is a document linked to the reimbursement payment. So although it's not for health itself, it's a very good one and has been used in several studies. So we got to collect all those information. And this is the one using some asthma-related hospitalization. Nelson knows this paper, I bet. Is a doctoral student. She just finished her doctoral training. And this is a very descriptive hospitalization for asthma over the years, over time, when we use some GIS information coding the vulnerability area of the city. So as you can see here, there's two lines here. You see it's very interesting because all over the world, asthma is increasing, but hospitalization for asthma is decreasing, at least in Belo Horizonte. But as you can see, it's decreasing, but still we have this big gap between the formal city with the vulnerable city that is called. When you see the geographical, the vulnerability over here, now using some spatial tools, you see that still we have all those little spots that are all overlapping with the slums area. Another outcome that we use is external cause in children and adolescents. We use the same thing. It's a very preliminary result. We have those, but we are comparing these children, the hospitalization for accidents and violence, and we see that accidents are going down according to age. And it is very interesting that informal cities is getting down a little bit more down than the formal city. But on the other hand, the violence is, according to the age, goes up related to the age. When we see the causes of that, we can see here the formal city and here the informal city. So you see here this little bar, the red one, where is the falls. Sorry, because it's very small, it's the format. But the falls here are very important according to age groups, and as well some hospitalization due to aggressions or violence. So we see that this difference is very huge in the city as a whole. The other outcome we've been looking at is the adolescent fertility rate. Now we use here the information system of live birth, and we are comparing the fertility rates of adolescents in the formal and informal city using the number of live births among women 15 to 18 divided by the number of females in the same age for 1,000 live births. Again, we see the same picture. The fertility rate in adolescents, although it's going down, we have this huge gap between informal and informal city. Dengue disease, another way, a report of a notifiable disease system. We are looking at that, and again, we see these concentrations of the density concentration using some kernel distribute in the city. So we see that the risk of dengue in 14 years was 2.3 higher when you compare areas of higher and lower vulnerability. So we're still going on looking the same picture that we saw in 2005. Now we're trying to see some trends over time. And right now we've been working a lot in the mortality by homicides. Do you want to present? Okay. So now we are using this, the mortality data. And we did an age period cohort effect in homicide mortality in children using the same data, and you see this picture. It's unbelievable, this evitable health outcome and how it's so huge, the impact in the cities, even in the formal city, but if you see the vulnerable area, it's really much higher. And when we see, after this 12 years old, and the risk is very high when you compare them. And then using the effects of period on homicide mortality, we use this intrinsic estimator factor in this age period birth control analysis. We see here a very interesting trend. This is the vulnerable areas, and this is the formal city. And we have this inflection here that we are trying to understand what's happening here. We don't have the evidence, but there's something going on here in the city that we are trying to understand. Because if we look back on the other graphics, we will see some inflection around this time as well. Perhaps it could be something related to the intervention, but we don't know. So in this sense, we decided to understand the mortality for all population, doing some analysis, comparing some percentual reduction of rates, comparing now the intervention, where the intervention took place or is taking place, and compared to the villas and favelas where intervention did not happen yet. We did some analysis, and I'm going to present you. We used some, not all of them, because as you remember, some of them are very scattered and distributed over the seat. Over 50?
Yeah, we are.
Okay. And we compared them. The great thing that we did was map the intervention. So we had to go back to the intervention, map all the interventions, this pink one, that we could compare one villa with the intervention, the other one without the intervention. I'm going through this is plotting the homicides by sex, by gender, by race, and we see here this high mortality rate according to one villa with and without the intervention, very similar, but compared to the formal city. And we can see here some difference here, compare one with the intervention, the other one without the intervention. The changes here are very remarkable between comparing the intervention. This is the intervention itself when it finished, and we see this line, this mortality line here. We did some Poisson regression, and we see that the time of exposure after the intervention is highly significant for decrease the mortality rate over time. And we also did some case studies looking at some specifically one area, looking also the density of case pre and post intervention, doing some density, and we see the movement, the direction trend, the movement before the intervention, after the intervention, or looking at some spatial analysis. Compare this standard deviation of the eclipse of this movement before and after. We see that there is a displacement, which we don't know what means. And also the distance between using the near tool, the distance pre-intervention of the outcome compared to the post-intervention moved away. We don't know what it means exactly. We are in phase 2. We did this household survey. We use household 600 adults and 80 adolescents. And now we have this all to do as the next step. Thank you very much.
I think we can move on to Alex. There's a, yeah, right, okay, yeah, go ahead, Alex. If there's a quick clarification question for Valeska at this point, we could do that. If not, we can move on and save questions for the end. Okay, go ahead.
So I'm going to be talking about rodent injuries in general, and a little bit about a project I did for my dissertation in Peru that looks at some of the policies in terms of road infrastructure and how those related to road traffic injuries. It gets up. It's open down there. But there's also implications in a lot of low and middle income countries in terms of how those transport policies affect injuries. So overall, injuries, there's about 1.3 traffic million traffic deaths per year annually. A lot of these are pedestrians in low and middle income countries, in contrast to high income countries. In Latin America, the rate of traffic fatalities you can see here per population varies quite drastically as we go across the spectrum. And specifically, like, when we look at the percentage of these fatalities that are pedestrians and cyclists, we can see, some countries have lower rates. Others, like Peru, for example, where I did the work, 74% of the road traffic fatalities are pedestrians, which brought my attention to working there. So in terms of Lima and Callao, where I did the research, these are from some data from combining mobility data as well as traffic injury. Just an example to give you an idea of what the situation looks like here. And so if you look at person trips per year in the millions versus the fatalities and injuries for these trips, public transport and some of the other motorized transport modalities have lower rates of fatalities. But when we look at these vulnerable road users, pedestrians and cyclists, they have a much higher rate of fatality per trips taken, and even their injury rates, especially for the cyclists, is substantially higher than the other modalities. And so so this brought to question in my mind, well, what are some of the things leading to this? And if you've ever taken a chance to walk around Lima, you might understand that there's a lot of infrastructure changes and issues that might be able to resolve this problem. So in high-income settings, this is an example of what some of the ideal interventions we might want to do on roads, to try to make them safer for all road users. This is a pre-treatment road, and this would be post-treatment. And what they've done here is they've added a bus lane. There's a lane for cyclists. The car travel lanes are much reduced compared to up here. So this helps reduce the exposure of pedestrians and cyclists to getting struck by them. We have a nice crossing area for the pedestrians. So these things, they're good for both for promoting people to want to walk and bike more in these areas, but also they're good for road traffic injuries. Whereas in a lot of low income settings, an issue that these things are addressing majorly is speeding. And these interventions help reduce speeding, which is really the prime factor that leads to pedestrian death and serious injury. So this map is from the World Health Organization. It shows where laws in urban areas have require speeds to be less than 50 kilometers per hour, which is roughly the inflection point where pedestrian fatalities and cyclist fatalities begin to increase substantially. It's shown in this graph here. This is in miles per hour, but about 50 kilometers is about right around here. And so reducing speed in these urban areas is really important to preventing pedestrian injuries, and some of this is having traffic control and having areas where pedestrians can cross the road, separating them from one another, from the motor vehicle travel. So this is an example of what a very large intersection in Lima looks like. It's an ocean of road. So the poor woman and child here, there's not really an option for crossing this other way here except for just kind of go out into traffic. And technically they should be crossing on a crosswalk that's over here on the other side, but that's not convenient, when you're trying to get to a bus stop. And so it's very confusing, some of the configurations in this example. And so I wanted to look at some of these issues and try to understand, well, what factors might be related to pedestrian collisions. Another factor that's important is the motorization rate that's happening in these countries. And Peru is a prime example where there's been a huge change in the number of motorized vehicles, especially in Lima. This graph shows 40 years of change in number of passenger cars per 1,000 people, as well as GDP changes in each of these countries here. So the longer and steeper a line is, the higher the motorization rate over that 40-year period. So China, for example, had a substantial increase in motorization. Some of the other countries like Chile or Oman, much flatter, much shorter distances, so they haven't had as much motorization change in this time period. So this is another key factor, because if there's more motor vehicles on the road, the more opportunity to hit pedestrians and cyclists. And if the road infrastructure is not designed to handle that, then it really puts them at high risk. So I wanted to look at this in Peru, and because there's over 13,000 pedestrian collisions per year in Lima, it was not possible to study all those locations, so I did a matched case control study of a selection of those. So there was 137 pairs we visited, where we looked at the pedestrian crossing areas rather than the pedestrians themselves as the cases. And the controls were locations that were similar in some of the characteristics and nearby, to compare some of the key things of interest, which were signalization, the presence of public transit stops, and then a number of other factors, like if there are street vendors or sidewalks present and things like that. And so this would be an example of like an intersection. So this would be like the index crossing area where the person had been hit, and then we'd find a control and find a comparable crossing area there. So in terms of the characteristics of the people who have been struck and where they have been hit, at intersection locations, a lot of them were these higher volume roads, which isn't really surprising. At the mid blocks, though, there's a little bit more of these residential areas. So and this was, I don't have that breakdown here, but a lot of these individuals that were hit here were children under the age of 18 who might be playing out in the street in those areas, and so are more vulnerable to getting hit in those locations rather than at an intersection. In terms of gender differences, there's a slight difference here. I'm not sure why there would be differences here, but it was something that we observed in terms of a little bit of a different balance there. And then in terms of the vehicles that are striking pedestrians, even though only 25% of trips in Lima are by private passenger vehicle types, they are hitting most of the people there, at least in the people that we looked at in our study. Motorcycles are a substantial number, and this is mostly vehicles known as a mototaxi. It's kind of a three-wheel motorized rickshaw, some people call them. And then bus, which a lot of people gets a lot of blame for hitting people because when it happens, it's very public. Actually, don't hit that many people compared to other other types of transport. So when we looked at some of the kind of baseline characteristics that we were kind of interested in trying to match the locations on, in terms of marked crosswalks, the intersections, they were more common, but still not as common as we might expect. The mid-blocks, they were fairly rare. In terms of the vehicle volumes, intersections had a much higher volumes. These tended to be much higher, you can see arterial type roads. Also, the pedestrian volumes were much more large at these types of locations. Speeds were pretty even throughout the different areas in terms of mean speed, though there may be some slight differences in terms of the maximum speeds that we measured, which we did with like a speed gun. So in terms of the first aim to look at pedestrian signalization, so a number of pedestrian signals have been installed throughout the city, probably over a 2 or 3 period before I had done this research, and these ones are a little bit older than that maybe, but these were kind of the newer ones that had these countdown signals, and I had expected, these might help, people make decisions about crossing the road. But in terms of what we observed, where there was any visible traffic signal, which you can see in this case, there's no traffic signal that the pedestrians can see when they're crossing. Even those locations didn't seem to make, there was not a substantial difference there between there and not having a signal. It's a little bit elevated, but not significantly different. And then even having the pedestrian signal is kind of a similar case. And surprisingly, having a longer duration of a signal for pedestrians actually seemed to have a higher risk of pedestrians getting hit there. And so kind of the implication of this seemed to be that, this is a user behavior dependent type intervention, and so people don't always adhere to the signals, drivers don't adhere to the signals all the time, and so we were trying to do something good, and it might draw more people, it might actually put them at more risk potentially. So it's something to think about in terms of when we in those types of policies and installing these, they sound good, they sound like good technology, but there's other implications sometimes. In terms of public transit stops, so Lima has a privatized transit system mostly. There's like 600 different companies that run their own individual bus lines like this. It's a very capitalistic system. It's very efficient in terms of being able to get anywhere in the city, but there's a lot of, so each individual vehicle is often also driven by someone that doesn't own the bus. It's owned by an individual person it's not owned by the company that gets the contract. So there's a lot of separation between who gets the bus line and who actually drives the bus. And so there's a lot of crazy things that happen, I guess you could say, around bus stops trying to get passengers. A lot of competition because that's how the bus drivers get paid, is by getting passengers. And so around the bus stops, they're required to stop at these places that have a sign, but people often don't want to stop at the sign. They want to stop at the elevators. Oh no! Do not use elevators. Got an emergency? Keep on going?
Let me find out what's going on.
Okay.
Well, at least we have a regulated fire code.
Yeah. Safety first.
Oh.
An emergency has been reported in this building. Please cease operations.
Huracán Irma. El huracán Irma.
As I was saying, there were, so they're saying Lima has a very, the privatized transport system there, like, the city tries to regulate it by having places where people they're supposed to stop, but as I was saying, buses and the passengers, often they don't want to stop where, the signs are, because they're not very regular. They're 3 or 4 blocks apart usually. For most people, they want to stop right in front of their house if they can, and so, the buses will stop and they'll pick up people, just on this picture here, that will stop them because they want more passengers too. So there's incentives not to stop here if there's people waiting or they want to get off. And so we looked at, both locations where there was these official bus stops and then places where there weren't. We couldn't really study the behaviors of the buses themselves, which might lead passengers off into the traffic, or might do some maneuvers that are a little bit less safe, for the rest of the vehicle drivers around there. But anyway, so what we found is that at the places where there was any bus stop, there was an elevated risk of a pedestrian collision, and at the authorized bus stops, it was actually twice as high as this. And so once again, it was something that kind of expected, but it was a little more dramatic than it expected, perhaps, in terms of this might be an application for this behaviors that are happening here might be putting people more at risk because they're trying to get there, despite controlling for pedestrian and vehicle volumes at these locations. And then finally, we wanted to look at some other features of the road here. That are related to some policies. These street vending is something that's permitted there. People can get permits to do it. And we found that these locations where there were actually street vendors, there was a little bit higher risk of also pedestrians getting hit there. Might be because people have to walk around there in the road because the sidewalks are blocked off, and that exposes people more often to road traffic. Where there's parking also was an issue. These kinds of places like this that have a roll-up curb where people can park on the sidewalk also usually force pedestrians into the road, where they once again can get hit by vehicles. But if we have places that had like a nice kind of edged curb as well as the sidewalks themselves, these locations had a substantially lower risk of pedestrians getting struck. And so this is a good, potentially good benefit in these areas to separate the pedestrians from traffic, at least when they're walking along the side of the road. When they're crossing is a different story. So overall, just some implications for this. So, I would advocate for any transport policy type studies to look at both fatal and non-fatal injuries, and kind of tell you a different picture sometimes than just looking at fatal injuries, because those are often involve a lot of other factors than just the road environment or the policies. Behavior-dependent features might be less effective. They might have to think of ways of how they might work in these local contexts, where there's much different mix of traffic than the place when they're developed. A traffic signal here, most people are going to respect. In other places, it might be just kind of good advice. And then separating the pedestrians from the vehicles is always very important, finding ways to do that both in time and space. And then finally, what is the effect of motorization, and policies that promote more people to get more vehicles and to want to use private vehicles, whether it's their own vehicle or taxi, is something important to consider in other studies, I would say. So this is just some acknowledgement of the support I had previously, current support. And the Policía Nacional de Peru were very kind of letting me access their records. They're supposed to allow you, but they had to give extra permission to allow me to access them. And then also the Consejo de Transporte Bilbao and Callao, which were helpful in providing a lot of the geographic files. So thank you all for your time.
Thank you. As we transition to Nelson, I don't know if you have any questions for Alex. Yes, go ahead, Jen.
Yeah.
Do you think, do you know anything about the temporality of the intersection signals, like perhaps whether they're going in after there are more accidents that have happened at that intersection?
Well, so most of these ones came in, it's just kind of a big program to make them smart traffic. So it's all like major avenues in Peru, in Lima. We received a bunch of these signals that have the countdowns and everything all at the same time. It was more of a push to try to modernize the infrastructure rather than response to collisions. And the collisions are, there's not really a good monitoring of those, except for maybe some of the fatal ones, but there's a disconnect between like the people who build the transportation versus like who's collecting the road injury data. So while the police collect that, transportation does their own thing, and then Ministry of Health might figure out later, like who's a Rodent injury victim. But so there's not, I don't see there's much of a connection between those as there might be in some places here. Okay.
Okay, so we'll have more time hopefully at the end for additional questions. Go ahead.
Okay, well, thank you for the invitation to be here. I'll be, I mean, my talk has a bit of overlap with the other talks here, and because I'll be focusing most on air pollution and mobility, which are two major issues for Latin American cities in general. And I'm talking a little bit about EMF, electromagnetic fields, which is also a concern for some cities in Latin America. I've been done some studies in São Paulo, where I live, and that has some policy implications. That's why I thought it would be interesting for this presentation here. Well, in terms of air pollution, I mean, I know most of you know, I mean, Latin America, the cities in Latin America have one of the most higher levels of air pollution, apart from China, which I think are now the toppest. But air pollution is a big issue in Latin America, and there has been several studies, isolated studies in cities all over Latin America, mostly concentrated in Mexico, Chile, in Brazil, and some cities in these three countries. And this was the first study that we tried to do a combined research or combined analysis using a standard protocol analyzing time series of air pollution data and mortality for 9 cities in Latin America. In Mexico, 3 cities in Mexico, 3 in Chile, and 3 in Brazil. And the idea he was trying to come up with like a common impact of air pollution for those cities that could be used in policy in terms of informing policymakers in the region, especially because most of countries in Latin America still are using old standards for air pollution, and I'm going to show you this in the next slide. Basically, the idea he was using, I mean, for these 9 cities was like a time series using standard procedures for analyzing the time series for mortality, for different causes of mortality. And I'm going to just show one of the outcomes, that is all cause mortality for the 9 cities, and then we come up with a meta-analysis of the results about 0.7% increase in mortality, all-cause old age mortality for 10 microgram per cubic meter increase in PM10, which is in terms of comparing to the you know, other places in the world, is sort of kind of in the same range of values for most places, especially here in America or in Europe. There's some studies in Europe, some in America, in North America, which means that we are sort of, you know, having the same problem that everybody has in all over the places. But the difference in Latin America, this is our study here. The difference is that, as I said, most of the countries or most of the places in Latin America still are using the old regulations and old guidelines for, you know, permitted levels of air pollution. Here we have the actual new guideline for PM10 from WHO. This is the European guideline, and you can see all the cities in Latin America, the cities that we have measurements, this is for PM 2.5, are well above the WHO guidelines. And the WHO is already changing these guidelines, perhaps lowering a bit more in the next years. But most of the countries, in Brazil at least, even now we are still discussing about adopting the 20 micrograms per cubic meter guideline, but still hasn't been enforced. So the idea was to, you know, show that air pollution is an important problem in Latin America, and especially try to lower the guidelines or the standards for each country. We did also some, you know, health impact assessment using the estimates that we get from these cities, actually using some impact functions from, you know, cohort studies that have been conducted in North America and in Europe, and we come up with some interesting figures. This is comparing that as if we comply with the actual guidelines, the new guidelines for PM10, in the period of 15 years, from 2010 to 2025, only the three cities, Mexico City, Santiago, and São Paulo, if we complying with the actual guidelines, we could avert about, only in these three cities, about 100,000 deaths, all-cause mortality, and more than 2 million acute respiratory infections in children. And these are very huge impacts, which means just, if you lower all levels of air pollution, we could avoid all these health effects. And this has been, discussed a lot in terms of, lowering the guidelines. As I mentioned, I know that in some other countries, they've been discussing adopting the new guidelines for, they're not new anymore, the guidelines from WHO. And in Brazil, this might happen, in the coming years. A related issue in terms of transport policies is a study that we conducted there in terms of, 3 different policies that have been evaluated in terms of, their impact, in terms of, health impacts, either short-term or medium to long-term impacts. One is changes in fuel composition, especially in Brazil, that we have been using alcohol as a fuel for running cars. And in the past few years, there are more cars running on alcohol because of prices than on gas. And this has also an impact on air pollution. We also had things on emission limits. The emission limits have been decreasing all over the years, although they had gone to a stage now that there's not more technology to go further down. And also a policy that has been placed in few places in Mexico, Santiago, and São Paulo again, and perhaps some other cities, which is avoiding cars to circulate in certain, especially in the central areas of the city, in certain hours of the day or certain periods of the year, especially when the air pollution usually is higher. What we observe, and this is just for São Paulo, what we observe in terms of the restriction for vehicles to circulate, is that there is an impact. This is when the restriction was enforced in São Paulo. Basically, it happens only during 3 years. And there are, I analyzed the previous 3 years just to have a comparison here. And the red dots here are the days when the circulation was enforced. But as you could see, there was a declining trend of PM10 or for carbon monoxide, independent of the restriction of the policy. And this trend was mostly driven by technology, changes in fuel composition, and other measures that have been taking sort of a more longer time. So the impact of the restriction wasn't really very effective. And in fact, what we observed in São Paulo, and this has also been reported in some other places, is that when you start a policy like prohibiting people to drive their cars, they trying to do another way. They trying to find another car, or buying a sort of an older car, which is much more polluting, and drive on those days that cannot drive. And just to show you an idea, and I think Alex has shown this a bit on a different scale. This is just for São Paulo, but this is the level of motorization that we have in São Paulo from 1990 to 2015. And as you can see, this is the population growth during this period, and this is the car increase during this period. And from 1990, we have about nearly 3 citizens for each car in the city, and we are going down to 1.5 individuals for each car, and perhaps now or in a few years we're going to have 1 car per individual, which is a very, very huge increase in motorization index. And I don't know if any of you have been to São Paulo, but traffic jams are really a nightmare, and people take hours on mobility, so it is a major issue. Every time we have elections, this is one of the issues that come up in terms of concerns for the population, is the time they spend in traffic every day. And as a consequence of this is the main speed of vehicles in São Paulo around the same period from the 1980s up to 2010. and we start here about 30 kilometers per hour as a mean speed, and this has been steadily declining over the years, and is about now 15 kilometers per hour, and perhaps it's even less nowadays. So that's why people feel it every day in terms of commuting time. And this is another policy-related study that I've been involved with, which is the effect of an intervention. Actually, was sort of a natural experiment, quasi-experiment. This is the effect of a beltway that was still being built in São Paulo. This is the São Paulo city here. This is the great metropolitan area, and this is the ring belt that's being built around São Paulo. Still, I think this part here hasn't still been finished. And the whole thing is about nearly, I think it's 170 kilometers. And the idea is to, I mean, this is the port of Santos, one of the major ports we have in Brazil or in South America. And most of the lorries, the heavy duty vehicles coming from the north, they had to cross in the middle of the city to get access to the port. And there was a major avenue here where they all pass by. And when we have the southern section of this, the southern section of this belt open, then all the vehicles, the heavy-duty vehicles that are crossing the city, they could divert through here and go straight to the port without crossing the city. So this had a major impact, the southern section. It opened in March 2010, and then we had an evaluation of the impact of this intervention, this mobility intervention that was in place in São Paulo. Just to have an idea of the design, I mean, this is the area that we compare. I mean, a very central area, very influenced by that avenue that has been the major focus of this southern section of the ring belt. And we compare with another area surrounding it, which was also influenced by the opening of this southern section. And two sort of control areas. One was, again, surrounding the major metropolitan area, and one very far away where we could compare either levels of air pollution. We compare also hospitalization for respiratory disease and traffic. These are just some information. I mean, what this southern belt avoided was around 250,000 trucks per month were, avoided on that avenue, that major avenue, and not only that major avenue, but in crossing the whole city. And what we observed along the years was that, well, not along the years, but I mean, just after, this is when the southern part was open, we have a significant drop in the congestion, which is the blue line here, and also on nitrogen oxides, one of the measures of air pollution. So we have this drop here, but as you can see, and I think I have a, let's see, yeah. Although the drop in levels of NOx remain, I mean, the congestion after a few months started increasing again, which is to do with this fundamental law of road congestion. As soon as you have more space in the streets, I mean, you took the truckies, the heavy duty vehicles out, then people get their cars and put on the streets. Although they are better in terms of emissions, air pollution remain lower, but congestion start increasing again. So it's not a matter of taking the cars, the heavy duty vehicles out, but you have to do other measures to avoid people using their cars. So in this sort of a natural experiment, we have some relief in traffic congestion, some decrease in air pollutions, and also in hospital admissions for respiratory disease, which is the green line here, which is still sort of lower. Although respiratory admissions is quite seasonal, and there has been some increase again after this was opened in 2010, so there's been some years now. And finally, I'm going to talk just a bit about electromagnetic fields and health, which is completely different from transport and policy, transport and mobility, air pollution and mobility, but it is also a concern in São Paulo because we have around 900 kilometers of, high voltage transmission lines surrounding or crossing the city, and sometimes in areas very, very populated, densely populated. This is the map, the whole metropolitan area of São Paulo, and this is the city, and you see, there's quite a lot of transmission lines crossing the city, and this was, for a period, there was a concern, because some wealthy neighborhoods where they had these transmission lines, they were complaining because of the risks, and then we did this study, which was basically a case control design, where we use GIS procedures, we geocoded, we georeferenced each path, and we measured their distance to the transmission line, because the electromagnetic field, the main exposure is based on distance. As close you are to the transmission line, higher your exposure. And we got some signals showing that the closer you are to the transmission line, higher is your risk, in this case of leukemia, which is the most related disease to electromagnetic fields. Although it's not statistically significant, but there is a trend here. The closer you are, you have a higher risk. And this was important because we also evaluated, the population which are living closer to these transmission lines, and we discovered they are, as expected, they were all in lower socioeconomic position, and this has been published a lot in the press in São Paulo, and there's been quite a lot of discussions in terms of enforcing the regulations in terms of getting these transmission lines with distance. Actually, there is a law that regulates this, but not every time is sort of complied. And after this research, this has been quite a lot of discussion, so there quite an impact in terms of trying to avoid this exposure. And that was it. Thank you.
Yeah, quick questions. Just what, so I'm sure this happened in Brazil, it certainly happened in Argentina. Part of the big problem is that many of these countries have had policies that have incentivized people getting more cars, right?
Yeah.
Like in Argentina as well, get a new car, there's special loans. And so, and I don't think that the issues of the health impacts have entered into that kind of discussion about, on a grander scale, because we saw this in Alex's example, we saw it here, an underlying problem is just the sheer number of cars, right?
I think it's been changing. I remember, about 10, 15, perhaps 20 years ago, there was a mayor that he said that congestion was a sign of prosperity. Too many cars are like a sign of prosperity, and perhaps many people think about it like that still. But as you get, suffering from, commuting every day on traffic or getting the air pollution, because air pollution became also a concern for many people, and I think this has been changing. And also, as soon as you start having more public transport and the public transport network becomes better, people start, changing, turning to public transport. And I know, of course, this is not it's my personal experience, and some few friends that they stopped driving cars and decided using public transport because it was faster, better, and healthier in a way. So,
thank you. So I think we had 4 very nice examples that are very, I think, really nice complementary policy relevant work. And now Ricardo is going to talk, right? A little bit about a scoping review that we're engaging in as part of the Cerebral project.
Yeah.
Various typologies of urban health relevant policies.
Thank you, Anna. Thank you, Anna's team. It's wonderful to be here back again. It all started 2 years ago. It's amazing how much we're going through. And let me give you just a little bit background on this, what Anna was saying about the scoping paper or the scoping policy paper that we are preparing. And this is based mostly in the Welcome Trust. You all know what is the Welcome Trust project, and also in the Salud Verbal network. And one of the ideas was, one of the agreements on the project that it started was, what people talking when they're talking about urban health. It's not about people, it's about the academy, and the decision-making people, meaning governments. So when you ask them, you say, okay, what is urban health for you? And you have so many answers as people you survey on that. So one of the main things of the Welcome Trust project, and also with the Latin American network, was to find out what was people talking, meaning governments and meaning the academies. Some other thing is I'm just a spoken person of the group, and I asked my colleagues, why do you want to put the names here? And they say something about the methodology we're using. It was a very strange answer. There are some of them in the room, but I will not identify them, because especially coming from the academics, they always like, they always like to put the names and the PhDs and all that stuff. But they say, okay, no, not now. Now we want to keep the group secret. And I think I don't know what's behind that, but maybe something. They answered something about the methodology we're using, the Peters methodologies, to do this scoping reviews. And the other thing is especially because the group is growing very, very fast. As we move forward, the group is moving forward also. So it started with what is urban health, and then the other question was, are there at the city level or at the territorial level or mostly at the city level, health inequalities, and how do those inequalities express themselves? Because as we analyze what was the history of urban health, you tend to look at everything that is happening at the whole city level. So, for instance, we have this short paper on homicides, for instance. So when you analyze homicides, you kind of see, or say, in Santiago, homicides are at a rate of whatever. But then, again, if you go deep, some parts of the city have higher rates of homicides. In the case, this is in the case of Santiago. And it's about poverty, it's about density. So actually, then comes the question, what are the urban determinants of how urban health inequalities are expressed at the territorial and at the city level? That was one of the main questions. And so then came the thesis that started all this, that is, people get sick, places get sick. So if you go in Philadelphia, you can find some places that are doing okay, but there are some places that maybe are not doing that good. And if you go to Latin America, you have huge inequalities in terms of the quality of the spaces. And so the diagnosis is there. We try to put up some kind of a medical analysis of spaces, but then policy recommendation, but because our group is working mostly on the policy programs and the project side. So at the end of the project, hopefully, we could address the question of which places, which policies, which programs, and which projects. Finally, bridging knowledge with policy action. Welcome Trust is mostly an academic kind of project, but one of the aspects, one of the four main groups or aspects that are there in the project is to bridge knowledge with policy recommendation, with policy action. So then we came in with this scope and review of policy approaches using the Peters, maybe you know the Peters methodology, this very secret methodology, by the way. And one of the main questions was, what happened in between Habitat 2 and the New Urban Agenda? The New Urban Agenda meaning the agenda that was agreed on Quito, October 2016. By the way, this made something here. In between 2014 and 2016, 5 international main agendas were approved: the climate change agenda, the SDGs, the New Urban Agenda, the Sendai Action Framework, and the financing development in Addis Ababa. So I don't know why that happened, because in 2 years, this big, huge agenda. So the other question was, what is on the new urban agenda about urban health? And what you find, at least starting from the back, I will go back to the beginning of Habitat 2, is that it's a scattering. It's something that you don't find a chapter in urban health. Urban health is there. There's some issues of urban health. It's mobility, it's pollution, but you don't have kind of, I'm not kind of addressing and evaluating that thing, but it's just that. It's not there a chapter in urban health. So maybe we have to go that way, not address urban health as an urban health chapter, because and we can mainly move on the issues of urban health, or we can change and now put forward a huge chapter in urban health, meaning all the things that we are searching and researching on this. And so this is the methodology, the research questions. The first question is this one: what happened in between Habitat 2 and Habitat 3, 20 years? Searching, selection, charting, collating, summarizing, reporting results, and consultation. That's the Peters methodology. And so aims to check out what happened 20 years, in 20 years, in terms of policy recommendations or policy analysis. Policies and interventions, this is very important. It's about policies, it's about programs, and it's about projects. So the search is not only about all programs or policies, and it moves from case studies where you can identify mostly projects to a more broad view that are the policies that countries kind of put forward in terms of urban health. On urban conglomerations that improve the health, the potential of improving health, and national social and health policies that impact urban populations. That's the thing. So one comes from the urban policies, the other one comes from the health policies, and they meet and converge in some point. But for instance, health ministries, are they putting forward some specifics on urban health policies, or is it just health policies? And what happens at the local and at a more urban level in terms of putting forward, again, health policies? This is the main conceptual framework from local structure determinants all the way to try to find out these inequalities in health, in urban health, and finally, I think we are around here, but we have to move all the way through to the others. 6 steps, as we say, that in fact, there's research questions. This is very important. There's a question already there. It's identifying or it's evaluating also. So at the end, that's something that we have to put into question, and we have to kind of talk about it and agree about it. It's only about identify, or the typologies that will come out of all this research will also need to be evaluated in terms of the performance over these 20 years, because if something was there, what happened with that in terms of impact, in terms of, but that's something that the group has to discuss. The research questions since Habitat 2, 20 years. Those are milestones, huh? Some things, I think we have a couple of things that were previous to also Habitat 2, 1996 in Istanbul. And we started dividing the group in terms of going deep into all that databases, websites, and so PubMed, STOR, ProQuest, some institutional ones, the ones at the NECLAC and the ones at the UNHabitat, coming on very fast, the development banks. And so the idea is, let's split and let's cover the most of the terrain as possible in terms of those data websites. These are the filters, so we started. Latin America or South America and the Caribbean, there's a lot of or, and sometimes it's a lot of and. So first filter, then the second filter is urban or city or cities or towns or municipal or district. These are kind of very technical things that are in searching this data, webs, policy or interventions or program or regulatory frameworks. That's also very important in terms of that creates an environment for projects, law, legislation, projects or plans. And these are the main issues, as we were saying, about urban health identified by the group, or kind of the filters that we are using searching on those. Social inequalities, mobilities, emission controls, Nelson, there you go. Comprehensive urban development, a little bit not that tangible maybe, promoting health behavior. So again, those are the filters, and then we come to the block 5, very specific of what does all that mean. And this is a web of science. This is one of the, this is an example. We are just moving in. We found total articles 395 on that, on the total thing, on the tobacco, on promoting healthy behavior, 112 and so forth. So we're doing this with all the databases, and it's huge, huh? By the way, it's huge. The amount of things that we are finding out. So we need to narrow out, actually, that was on the next phases. PubMed, most of you doctors, medical, you know what PubMed is. Same thing. Lilacs, again. This is a little bit few, but depends on the amount. But then the starting here is we double the language, we triple the languages. It's Portuguese, it's Spanish, it's in English. Going, Anna. This is the UN. The UN. You find that some other categories. At the end, we will try to find out typologies, different typologies. Some examples on the ECLAC, in the CEPAL web page, web database, and then we find some chapters and some books and some documents and some papers related to that, but mostly not one on urban health, but inside some of them dealing with the main issues. The selection of inclusion and exclusion criteria for the search. This is the whole peers, starting on the questions and finally ending on the studies included, charting the data. This is something that has to be on the next stages, and the typology of policies identified on the case of the region. We need to check out this through a consultation process with a kind of a board, or a scientific board that is part of the group and part of the Welcome Trust project, and that's where we are right now. Thank you very much.
This would be very useful to bring to light some of the things that have been going on in Latin America related to the message of urban health, and even to just make the link if it wasn't there before. So I know we're running a little bit late, but Jonathan, you want to share a few reflections based on what you've heard with us, and then we can have a little bit of conversation.
Sure. So I've been here making notes and kind of doing qualitative research on the fly, identifying themes from this N of 5. So two main things that jump out. It seems like in a lot of these presentations and studies, there was pretty robust evidence on the topic from abroad or other parts of Latin America, yet local research was conducted. And also in a number of the presentations, kind of the policy context and the political context, if you will, that would facilitate sustainability was also explored. And I think those are two really, really important things and two themes that jump out. So I just kind of have a question for the presenters, but also the larger room. So, you know, policy making and local policy making is a political process, and evidence is really just, you know, one piece in that process. So in terms of kind of what you guys think is the most important driving factors in translating evidence into policy and then having policies that really promote the health of populations in urban settings, So in terms of the evidence itself, I kind of see a hierarchy that came out of these presentations. So there is evidence on the topic or the intervention from a different context, be it abroad or a different part of the country. And then there is local evidence, but maybe in the form of health impact assessment, right? So less empirical, more kind of simulated. And then there is real empiric local data and evidence, locally conducted by local researchers. How much that matters to policymakers when having evidence influence policy, the extent to which it was conducted in local settings. Another thing, the role of relationships between the researchers and the policymakers, and how that plays into the translation of research into policy, and whether the policymakers were engaged before or after the research was conducted. And finally, the role of residents' and constituents' opinions, right? So there can be really clear evidence in favor of or against a policy intervention, and if constituents, the people living in the city, don't like it, if they don't want the roads closed on Saturdays for exercise, that's going to have an impact on the policymakers' decisions. And kind of what is the role of evidence, what is the role of constituents' opinions, and how can we work with constituents' opinions to implement evidence and form policies. So those are my thoughts, and I think it's just kind of open to everybody at this point.
Thank you. Thank you very good. So we have some time. Let's take a few minutes in case there's some questions or comments or discussion, and then we take a little break.
More comments to throw into the mix. I think a lot of the presentations revolved around, thinking about the city, the development and planning of the city. So my experience in a lot of African city settings is that whilst the municipal and the local government is really important, the pace of urbanization is such that actually the real mayors of the city are the private developers. Mm-hmm. So just as a missing stakeholder actor here, how, just to throw in the way that projects have interacted with those, because then on the policy level you might have buy-in, but actually the constraints are such that you don't get actual implementation.
Yeah.
Just a comment on the review that Jonathan mentioned. I mean, I think what drives the change or the interest, it changes from situation to situation. Taking the example that I just showed, I mean, in terms of the electromagnetic fields, this was a very wealthy neighborhood where they have a transmission line. They were all aware of the problem, so they start making quite a lot of noise about it, and going to the press, going to the media, and that makes the whole system to move towards trying to sort of satisfying their desire in terms of doing something about it. In other situations, I think that might happen. The mayor are the main developer, and so they want to do something. And in some other instances, I think the research community brings issues that become important because, at least in Brazil, I mean, when you publish a paper, sometimes it goes to the press, and that becomes sort of a discussion about it. And for instance, air pollution is not something that people perceive, but then if you start talking about it on the press, then people start getting it on their agenda, so that makes the whole thing to move. So I think that it changes from situation to situation, but I think all of them sort of converge to sort of trying to change the situation, something like that, yeah.
So, Jonathan, just to comment on what you said later.
Really loud. Oh,
so, just to comment on the. So, is like for the case of when we close the streets, what we have seen is that once you have community appropriation, actually that's one factor I underscore, it's more difficult for policymakers or to even to have other individuals to complain. However, people who have cars and power, they have a loud voice. And we had actually cases in Bogota, and also there's one in Santiago, where they said it's too long, the period that you close for the cars. So what should we do? And they were going to have a law to decrease the time. And we saw a community movement of individuals from low to middle SES. And we saw the same thing in Santiago. So I think that key factor of community appropriation, it's important for these programs. And for the message to our policymakers, what we have also learned from here that has been key factor for sustainable programs is the flexibility of the directors of the programs. The flexibility on how the arguments for the programs align with the preferences of the policymakers that are in the government. So we have seen how health has been important for some measures, how environment is important for other measures, how public spaces for other measures important. Now, actually for Bogota, now is happiness. Happiness, and now health, we don't see health in the case of Bogota, it's happiness, whatever that is. But I think the flexibility of the programs to change the mission, it has been important.
Yeah, regarding this housing regeneration, vulnerable area, regarding this intervention in vulnerable areas, although we know of that they have used some participatory instruments, which is very interesting. And also we have done some qualitative studies trying to understand these participatory tools that they have used and developed by it. It was not us that did that. They did previously to the intervention, and trying to combine the information that the population formed to participate with the urbanistic plane of the city, which means that the most important thing that they asked, they informed for this previous instrument was that they complain about violence. And it's interesting because violence is still there. So this is something that's why we're so much looking at homicides as a marker for violence. But we have learned using some qualitative studies, we have a team that are developing that there are some groups of the population of the involved and also outside the intervention area. They definitely agree after a long time, because we have in certain areas we have 10 years, 12 years of intervention right now. So they agree, or they think that the intervention was good. But of course, we have some group that are against, and they complain about barriers, because usually when we present that, people say, well, this is a capitalism interest to open to create some roads, to create some barriers. Yeah, that's true. I mean, it's unavoidable to say that there's no capitalism interest in this kind of intervention. It's very hard to disentangle that from a mayor intention, even if it's a left wing, which it was that during the Horizon. Now we are like that. We don't know where we are now. But anyway, there was an interest, some capitalist interest. But I think that's what we have to do to evaluate if the sustainability, if people like it, if like very close to the intervention, and if the sustainability of the intervention.
Can you go ahead? Yeah.
So I think related to this discussion is the question about North American cities, especially in the United States. We're for many years closing streets for this kind of project on a temporary basis was linked more to local economic activity than physical activity, because that would be left wing. But now the language is changing, including in our own city.
Yeah.
So I was wondering whether there are any insights about whether there's been a shift in municipal support for these kinds of projects in the United States that makes it more sustainable based upon simply public health outcomes.
Yeah, I'm not sure. I mean, I know a little bit about in Philadelphia. There've been we've started this, right? I think it's happened twice. We've had open streets.
We're talking about long-term.
But just a
permanent
one day.
Yeah,
We've done one, I think,
we've
now in
done
the
one day,
fall.
one day, two days over 2 years.
Right.
But the mayor has made public statements
Yes.
about long-term,
Yep.
maybe permanent
Well,
closure.
part of it is that, like, I mean, you also have to consider you know, like, so along the river, right, is
Yeah.
closed every week. And like, we have a lot of things that aren't programmed, so they're not necessarily, so like, that isn't something that would be considered open streets because it's not programmed.
Right.
But it's like a long-term thing that nobody really thinks of or triggers.
Definitely.
Which, I don't know if any of the other speakers, maybe this also leads into that. One of the things that was a theme that I noticed or that I'm struggling with has to do with kind of like scale and critical mass with some of these interventions before they're either popular with the public or they have the outcomes that we're interested in for physical activity, or even just what scale, like with the violence. It sounded like there's some evidence that maybe the violence is just shifting to a different area that wasn't part of the intervention. And so, you know, how do we think of both that like micro level individual neighborhoods, but also the macro level city, and then the way that those interact to kind of give us different outcomes. Which I think, you know, when we talk about Philadelphia, like maybe every other, like the open streets one, which is only once a year, twice a year, or even bike lanes, like which haven't been discussed very much, but you know, like how much connection do you need before it's actually usable? Things like that.
I think these are all very important questions. I mean, many of them are research questions, right? I think some would be, hopefully, through some of these collaborations, the Cellar Well project or other projects that are happening in other parts of the world, we'll be able to learn more about the drivers of what development and policy, chain of policy impact too, and then what can we learn across cities. So I think we should wrap up this session, take a break, 15 minutes, and then return. So thanks to all our speakers. I think this has been very stimulating, and thanks to all of you for listening and contributing. Thank you.
really excited about the conversation we've already been able to start. I feel like the diversity and the commonalities of the projects that we've just heard about is going to continue to play out over the coming days as we get into the symposium. I'm Gina Lavasi. I co-direct the Urban Health Collaborative, and I'm the Dornsife Associate Professor for Urban Health. And I'm really excited to introduce our next few speakers because in a way this was my fantasy, thinking about this symposium and the speakers and the room full of people that we're going to have access to in these couple of days. I wanted to see, is there a way to tap into this knowledge as we decide on priorities for our own urban health training, for our own global health training? What do we need the next generation of scholars and practitioners to be able to do, to be thinking about? And so I am really here, to learn from the folks that are going to be speaking in the next panel, and really eager also for the discussion that'll result afterwards. I think we're very committed to the idea of sort of Philadelphia and the cities we're working with in Latin America and throughout the world being very interconnected. I think one of the things that struck me out of the last session was the tension between wanting sort of local tailoring of our approaches, both to research and to policy, and then also sort of more generalizable understanding of what we can do, what are the complementary things that we need to do, what complements the evidence that we can build in terms of driving policy action, what complements the specific policies in terms of maximizing the health benefits. So I just want to, with that, kind of continue the interactive, informal tone that we set in the previous session and introduce the set of speakers. I'll just mention each of them, and you have more materials available. We're going to start by hearing from Tony Capone, who is a professor of planetary health at the University of Sydney. And then we're going to move to hear from Siddharth Agarwal, who is visiting us from Delhi, India, where he's the executive director of the Urban Health Research Center. We'll hear again from Valeska Caifa, who is with us from Belo Horizonte, and also Tallulah Oni, who we heard from during the Q&A last session, who's visiting from Cape Town, South Africa, where she's a senior lecturer at the School of Public Health at the University of Cape Town. So we'll really, move from a focus predominantly on Latin America to an even more global breadth in our discussion over this next bit. And so with that, I am eager to turn it over to Tony. Thank you.
Great. Well, look, thanks very much for that introduction, and I'm quite conscious that we're running a little bit behind time. So what I'd like to do, I really have one key message in terms of the training of the next generation of urban health researchers and urban health practitioners, that we need to do more ecological thinking in our research, in our capacity building, and in our engagement with policymakers. And really, this is not a new idea. I mean, it goes back at least as far as Hippocrates, who is, of course, the father of medicine, modern medicine. And one of his treatises on airs, waters and places in 400 BC. So really, in many ways, this is about reclaiming where we've come from in our work. And importantly, it's about acknowledging the Anthropocene, this epoch of humanity. As a human species, collectively, we're now changing planetary systems, the climate system being one important example. And always remembering that we have to think in a demographic context. So of course, we're talking about urbanization. We've moved from a Latin American scale to a global scale. And so here, the population of the world, the purple bars from 1950 projected through to 2030, seemingly inexorable increases through this phase, but very importantly, the blue line, the number of people living in the countryside, and the red line, the number of people living in cities. And for the foreseeable future, most population growth in cities, which is an enormous challenge for us, but also an opportunity. So this bit of this figure is the future careers of urban health researchers, urban health policymakers, urban managers, the opportunity to do better than we've done so far. From a human health point of view, this conclusion from the Lancet Commission on managing the health impacts of climate change in 2009. Climate change, the biggest global health threat of this century. Now, what's behind that? There must be a lot going on if it's the biggest health threat, and I think we can do no better than look at the work of the very eminent environmental epidemiologist Tony McMichael and his work on pathways between climate change and human health. Again, perhaps playing out here in the Americas, in the southern parts of the country and across the Caribbean in the coming days. So what's behind all this? What's the scope of this aspect of the ecological challenge? So climate change on the left, health impacts on the right, three broad categories of impacts. The direct impacts, the human health impacts of extreme weather events, heat waves, floods, fires, storms, water shortages. Very clear human health consequences from extreme weather events. Category 2, the indirect system-mediated impacts, can further be subcategorized into 3. Changes to physical systems and processes. We've heard quite a bit about urban air pollution this morning. There's an interaction between the weather and air pollution, and this affects the risk in a given city on a given day. For example, through higher levels of ozone formation at the ground level on very hot days. So we've got an interaction between climate, weather, air pollution levels as a result of motor cars, for example, in many cities, and the health consequences. Changes to biological processes and timings. Valeska mentioned dengue fever earlier today. Changes to the distribution and the abundance of those mosquito-borne vectors in the context of urbanisation and a changing climate. And then changes to broader ecosystem structure and function, both in the context of climate, but also in the context of urbanisation and loss of biodiversity. And then this third category, the flow-on effects via social, economic and demographic disruption in the context of climate change. Changes to livelihoods, for example, periods of drought in the Americas, elsewhere around the world, in the context of climate change, affecting the livelihoods of rural communities with flow-on consequences for the health of rural dwellers, but also urban dwellers, for example. So a wide range of connections between climate change and human health. And importantly, climate change and health has an important equity dimension. So this work from our colleague Jonathan Patz on mortality impacts of climate change in the year 2000, estimated annual deaths due to climate change. This is a scaled cartogram based on WHO regions of the world. So you can see where there's a disproportionate health impact already unfolding from climate change in sub-Saharan Africa and South Asia. But if we look at who's responsible for climate change, it's almost the polar opposite of that map. So this is countries scaled by cumulative emissions. And you can see that it's the countries where there's been major industrial revolutions. So here in the United States, for example, in the United Kingdom, Europe, Japan. So that great inequity between those least responsible already being most affected. But through all of that, there is also a very important positive story about climate change and health. And that's the concept of health co-benefits from the types of actions we need to take on climate change. And there was another Lancet series also in 2009 on this topic. And there's a number of very important urban examples here. So whether it's energy generation, the transition to renewable energy, less toxic air pollution from the production of energy, as well as less greenhouse gas emissions. So less health impacts in areas where coal is being used to generate electricity, for example, as we transition away from that. Urban mobility, good for physical and mental health if we're walking and cycling, as we've heard this morning, but also less carbon footprint from that urban transport task. Food systems, a vegetable-rich diet, better for our individual health as well as for planetary health. And that idea of co-benefits really brings us back to ecology. This work, for example, by the very eminent human ecologist Stephen Boyden, and what I think is his very elegant biosensitivity triangle. So every human activity, whether it's something we do as individuals or something we do collectively, has the potential for positive or negative impacts on our health, as well as positive or negative impacts on the health of planetary systems, the climate system, for example. And there are feedbacks when we think about that deeply. Human ecology also reminds us that we all share a set of universal health needs. We tend to focus in discussions like this on the biophysical health needs. We've heard quite a bit about aspects of these this morning, but we mustn't forget also the psychosocial needs. And these are at play in cities as well. And this brings me briefly to the Lancet Commission on Planetary Health, which I'll discuss a little bit more tomorrow, because I think I have another speaking opportunity tomorrow. But just to touch on this today, to bring it into the context. So this was a piece of work funded by the Rockefeller Foundation and a diverse group of folk from around the world, different regions, different disciplinary perspectives, chaired by Andy Haynes from the London School of Hygiene and Tropical Medicine. The report, published in 2015, Safeguarding Human Health in this Anthropocene Epoch. Importantly, this work builds on previous work over many years, including the work of the Brundtland Commission, for example, and the very first Rio summit in 1992, the work of the IPCC on climate change and health, the work of the Millennium Ecosystem Assessment when Kofi Annan was leading the UN system, the work of the Convention on Biological Diversity, on the nexus between health and biodiversity, and again, coming back to Tony McMichael, the environmental epidemiologist, who sounded the alarm about these issues with his book, Planetary Overload, more than 25 years ago now. So I'll talk more about this tomorrow, but by almost any measure, human health is better now than ever before across all regions of the world. Of course, still great inequities in Africa and South Asia, but everywhere health is improving. But to achieve this, we've exploited the planet at an unprecedented rate. So whether it's carbon dioxide emissions, which get a lot of attention, ocean acidification, energy use, global deforestation, water use, fertilizer use, just some examples there. And the concept of planetary boundaries from our geoscience colleagues. So what is planetary health? Put simply, planetary health is the health of human civilization and the state of natural systems on which it depends. And urbanization and urban health is an essential part of planetary health, because urbanization is now a planetary scale change process. There's a range of links, as I said, between various environmental changes, including urbanization and these direct ecosystem-mediated and indirect health effects. But again, a positive message perhaps to finish with. solutions do lie within reach and require a redefinition of prosperity to focus on quality of life and improved health for all, together with respect for the integrity of natural systems. And we identified in the Commission report 3 broad sets of challenges. Conceptual challenges, if you like, failures of imagination. We need genuine measures of human progress, not just to track what's happening with the economy and our gross domestic product or our gross city product, but also what's happening from a human perspective, from an environmental perspective. We have research and information challenges very relevant to the next generation of urban health researchers, of course, and importantly, getting beyond the disciplines to build knowledge that's relevant to policy and practice. And finally, governance challenges, if you like, failures of implementation. So how should we think about the well-being of future generations, moving from a focus on health equity just in the context of who's currently alive and about to be born, which we tend to focus on in public health, to the health of future generations, bringing that into the conversation as well. So more information at that link, a new global program that I'll mention a bit more about tomorrow that you're all welcome to join in, and a final quote from our eminent colleague Nancy Krieger from Harvard. And here Nancy's talking about this idea of an ecological fallacy in epidemiology that has really constrained our epidemiological approach. And Nancy argued in 2015 that the real ecological fallacy is to think that epidemiologists could ever understand the people's health except in societal, ecological, and hence historical context. So I think that's a key message for the future generation of urban health researchers and practitioners. Thanks very much.
So, a comment for your comments. The pathways that you put up at the beginning, the physical infrastructure note is about air pollution, which of course is critically important, but we've just had another instance where the physical infrastructure of cities as they develop uncontrolled, like Houston, has a huge impact in colliding with climate change.
Mm-hmm.
And we've seen microclimate changes in Atlanta and the fires outside Sydney. These are all examples to make policy changes in places like Africa as cities develop. Would you make a comment on that?
Look, yeah, it's enormously important. I mean, in the high-income countries, the big challenge is to constrain consumption, to make room for further development in low and middle-income countries. So the changes that we need to see with these SDGs, these new global development goals, are at least as much to happen here in this city as they are to happen in African slums, for example. So that's the opportunity there to make room for more development in low and middle income contexts. But what's the pattern of development going to be in those low and middle income countries? And can they leapfrog and not get stuck where we're now stuck in cities like Houston, for example, North American sprawling cities? We've touched on the critical importance of the motor car and the lock-in that comes from the sort of infrastructure investments that we see with new motorways, for example. And how do we avoid that? And clearly vested interests are at play, because in many countries the motor car is an important part of the economy. And I think it was raised earlier, perhaps by Anna, but also I think by others, that we have to get engaged in those discussions as public health practitioners, because that's really where the rubber hits the road, if you like, and we need less rubber on the road and more on the tracks of the trains.
Less concrete on the grass.
That's right.
I think we'll keep with the pattern from the previous panel, just having one or two clarifying questions. So I'd like to invite Siddharth to come up and continue the discussion.
Thank you.
Anna and Veena and everyone at Drexel for having me here. It is a pleasure as well as an honor to be here discussing before you, and I also have the pleasure of getting a chance to meet two very long-term friends and colleagues after a few years. I would just also preface by...
Do you mind to speak up a little bit so everyone can hear?
Okay. I would also wish to preface by mentioning that I might be the only person who is not primarily a university affiliated person. I do have university affiliation, so I do multidisciplinary teaching at Berkeley, Hopkins, and many other universities in other countries and India, but that's not my primary affiliation. So I think in some ways what I will share might be a little different from how the whole thing has been going. And these are some lessons from practice which would apply to contemporary as well as future practitioners and researchers. One lesson we should acknowledge is that many countries have traditionally been rural and are still primarily rural. So something, at least during the time that I was here, I did not hear, is that it's important for urbanists or urban health researchers and practitioners to not forget the fact that we still have a very large part of the world which is rural. And in many countries, it could be as high as 60% or even 70%. Some countries could still be 60 to 70% rural. So we should not forget that and not be guided by the idea of rapidly urbanizing a country which is still primarily rural, and just let it go at the pace that it is by its own people. The other thing which we have learned is that often government policy documents do mention the need for urban health. When we start proposing this as a policy shift, which we think is a shift, we will do well to understand the existing documents, which are not possibly publicized as an urban health policy, but there might be many other policy documents, plan documents, which already refer to the focus on urban health. And this is what we learned in India, that the 5-year plan document, India used to have 5-year plans. This very recent government has come up with the idea of a 15-year plan, but they haven't been able to prepare it so far. There was a national population policy and there was a national health policy. These 3 policy documents, which were fairly high-level documents, and many other documents, referred to the fact that India needed to focus on urban health and was not doing enough on urban health. So this was a good starting point for us to intervene into the policy, rather than going and tell them that, hey, we are someone who knows more than you all, and we have come to tell you something new, which is actually not the approach to follow. The second, this I have done. The next aspect which we've noticed, which Valeska also has been mentioning over time, and many researchers have done in many countries, is to unmask the health disparities within urban areas. Because if we compare rural and urban, in most countries, urban appears to be better at an aggregate level. we just heard Tony also say that overall health is improving, but then within that, we should acknowledge this, that there is a very large section of that urban society in that country, in that province, in that city, which suffers this level of poor health. So this is from India. This is the most recent available data, which had a large enough sample to be analyzed. So you will just imagine that these children would now be the engines of growth, because they will be providing the low cost, low wage labor to urbanizing India or to the industry, or whether they're just lifting weights from one place to the other. So it is these children, because they are the poorest. And if they were better nourished, they would obviously be contributing to the economy in a better way. This is another dimension which shows how mortality differs within urban India. So when we compare urban-rural, we get a very different picture. Urban appears better, but when we do it, yes, because I've been learning from you for a long time, so I couldn't have forgotten that. We learn from each other. I mean, I always feel that over the years we just forget that if, yes. The fourth message is that spatial maps help identify listed and unlisted neighborhoods. We may call them slums, we may call them informal settlements, whatever phrases people use across different countries of the world. And Valeska is another person who's done this, so her name shows up on that slide. Did you notice that? Because, you know, whatever I present is from many people. I have learned and I continue to learn. I want to remain a learner. I hope nature doesn't change this aspect of me. I am 55 years old. If I live till 75, I don't want to become an expert. I want to remain a learner, and I fully understand that what we do not know is far more than what we know. So this is one study that we did where across these 5 cities we found that a very large proportion of the slums or informal settlements or whatever term we want to use for them were not part of official lists. Interestingly, the Government of India's Ministry of Statistics, if you go to this, it also acknowledges that 49% of slums in India are not part of official lists. So for current as well as future, I'm using the word current all the time, and not only next generation professionals, because we should not miss the opportunity for those who are current professionals. Why should we not learn? There's no need for us to think that we've already learned and there's scope only for the newer people to learn. So one good thing to learn is that it is possible that other countries may also have ministries beyond the Ministry of Health who are bringing out statistics which we are not looking at. I was lucky to have some connections here, and I looked up there. I mean, the statistics is available online, but often we don't search everything, and we found that they had given this information. This is an example of a map, a city map showing listed slums. The red ones are unlisted. This is the complete picture. So this is how this goes. This is another map of a part of Mumbai. trying to bring stakeholders together helps if we want to take the policy in the direction that is most logical, because these stakeholders contribute to the directions. We shouldn't think that a group of researchers have figured out everything. And it's important to create opportunities for community stakeholders to interact with those who are higher up. I mean, usually considered to be higher up. They may not be humanistically higher up, but an important lesson is to have few clear and compelling messages. So the big people want to have you say things in few words. So if you see, this is how I used to say that. And it is strategic to work closely with government systems and influencers. It is sometimes important to understand that this is not very easy. We have to facilitate documentation within the system. Because if we write a document, a report, or the minutes of a meeting ourselves and submit it to the government, it carries no value. But if that documentation is within the government system, then it carries more meaning. Identifying champions within the system is helpful, and at all levels, including people like section officers, under secretaries, up to whichever level seems to have the time. Long term, urbanization is not going to end very fast. So we are all here for the very, very long term. This is a challenge in projects. Therefore, the way our organization approach is that we work on a deprojectized mode. Remain flexible and responsive to the situation. The situation is dynamic, doesn't remain the same, whether it is political, whether it is urbanization. Everything keeps evolving every 5-10 years. And this is to understand that things take very long. I'm not going to read all this, but you just see here that there were so many things that happened. I have not listed everything. And the National Urban Health Policy of India, which perhaps is the first ever policy on urban health by any country, has been launched many times by many persons. And our previous Prime Minister actually launched it twice. Yeah, just 2 more messages. So the 10th lesson that I have learned is that handheld support to national, provincial and city governments is a very important skill to acquire for present as well as for future practitioners and researchers. It is important to maintain a behind the scene presence, and this is an art. Avoid trying to take credit in the interest of the purpose, unless your purpose is to take credit. So let's not forget the reality. And that's the reason I had prefaced by saying that I am not primarily a university affiliate. One example from Urban Health, UHRC is the short form for the organization that I primarily represent, has helped a few states get their urban health program started. And only one state has acknowledged us. None of the others have. I've been able to get a few ministries put all illegal slums on the official list. None of them acknowledged me. But they used the language which they have not changed over the last 6 years. This is the last lesson. rethinking research. Just 3 points. Affluence and deprivation are juxtaposed, which we heard others say. Research directed at supporting and enabling the disadvantaged will be most useful. Experiences with disadvantaged communities will help present as well as future practitioners take things forward. This is a spatial map of a neighborhood. Sometimes hand-drawn maps can be done easily, can be done by less qualified people, and can have a lot of information. Anybody interested can discuss this with me later. Differential housing condition. This is one type of housing condition. This is another next to the railway track. Slightly better. This has a municipal tag as well. From Longfellow, perseverance is a great element of success. So we just continue. And make the invisible visible. I mean, I know many people have used this phrase, lend voice to the voiceless. I think we used it in that article as well. So, since these two have been used by many people and by myself, I didn't put an answer. This, of course, is famous from Helen Keller. Thank you for listening to me patiently. I know I exceeded the time by a couple of minutes.
Do we have a quick clarifying question before we move on?
Yeah, so whoever would want to discuss, please, I know there might be.
I'll hand it over to your longtime colleague. If I may.
Yeah.
After just two speakers, I feel a little bit like, oh gosh, I have to learn a lot. Anyway, again, and I'll be presenting something from the academic point of view. My friend Siddhartha, we've learned several things together in the last, I think it's 15 years, Tony. But anyway, I will present to you some reflections from global urban health leaders in terms of the academic point of view. I want to show you a very recent experience that we have had in the last 3 years, very local, which is a capacity building related to health and urban space. We call this CEL. CEL in Portuguese is sky, but it's health, saúde, and urban space, and espaço urbano, which means cell at the end. As you see here, we have several different teachers in this discipline that we have offered for now. We are in the third cycle, and we are from the School of Medicine. We have professors from the Department of Geography, Department of Urbanism and Projects from the School of Architecture, but we are all from the Federal University of Minas Gerais. We are breaking boundaries or barriers inside the university because our university has such a very rigid scheme and structure that doesn't allow us to trade between departments. Very different from here. So we just decided to create this very much stimulated by Tony and the experience in the International Institute of Global Health that I have had so far. So we know about that. I'm not going to do that, but we need to do this in terms of health and urban policies. So, as I had mentioned before, we decided to create this new course for master and doctoral students, and I told you the name, no? We have this, all those profiles in terms of teachers and students. We are in our, as I said, in our third season, as people like to say in the TV. And we've been changing, and we're trying to center in the urban health determinants and the urban living health disease process, the social determinants of health, the multi-level and system approach, the food environment and urban agriculture, the urban green space and health. We are trying and getting very interesting response from this participatory process in health, and also the urban intervention implication for health. We use traditional methods. We don't know, I mean, it's very hard to get out of the traditional methods, but we've tried some innovative methods. And the most interesting thing that each season we try a different one. So we are using some IT, some web maps and collaborative platforms, some environment assessment tools using especially the systematic social observation approach, and now introduce this essay, trying to make the students to think about the ideal versus the real city that they have or they live in their daily life. So students, they get familiar with urban politics that we cannot avoid. It doesn't mean that we know how to teach that, but they at least they get contact with the politics involved in the urban area, in the urban setting. And the challenges of reinventing urban planning, because we have to think about that, because we have, as we said before, as we heard before, we have to think about how to reinvent urban planning in the way that we can provide room for human beings. So this is one of our experience, the field case, that we use this IT at the university campus, because we're using some UAGID platform. And so people, they could go around the campus and qualify the campus and see how it was for the accessibility, habitability, the risks, and the universal design according to some architecture profile. We use, as we mentioned, the field work going to the slums. You showed before, some of you have been there. And they have to go and to understand the complexity of the slums in the city. They have to understand the process of urban regeneration. They have to understand the complexities related to the resettlement of some residents in new house within the area, and the controversial compensation of families, that this was part of the process there. And also to understand for those who moved away, because we have some. And they use the systematic social observation method, as well as in the first round, the IT tools. This is the group, and we have all the students with the professors and the teachers. This is the entrance of there is an office there that we could go, and we have an explanation from the urbanists, from the technical people, from the municipality. He could explain exactly what was going, where is the intervention are, and after that we go to the visit. The second experience that we have, it was something related to ecological learning, that we are doing some environmental preservation. So we did this field work in an ecological reserve, in a urban one, and trying to understand the green space ecologically preserved and extensive area in the city, trying to understand the sustainability of this area, and we use this physical environment observation that was designed by the professor involved. As you see, we look at this inside and try to understand the species, everything that was there. And the essay that we started in 2016 Those are some of the information. They could use some icographic, ico pictures, infographics, something reading, writing. Depends. The students, they organize themselves in groups and use some approach that they're completely free to do whatever they want in terms of pictures, photos, anything. And so these are some of the essays. And here I'm going to try to read that because it said, the ideal city would be the one that would provide a good quality of life for all its population, depending on the social class, race, or sexual option of each one of these individuals. It should be a place where economic and political relations would not overlap human relations. It should be a place of transformation, always aiming to equality in every way, from the economic to the gender equality, without forget, of course, health. So this is some essays that they showed. This is one of the essays that they say that the ideal city is an inclusive city, and showing some, some important features that they capture during the course, the discipline. And recently we are trying to, we used that two weeks ago, in our third temporary offer. We were in a public hearing. We brought all the students to a public hearing to discuss with the municipality representative about the genocide among black youth. Remember that picture that I showed? We stopped in this picture and discussed a lot with them. Students, stakeholders, any kind of NGOs. There was a lot of people inside the room. This was provided by the municipality. And we discussed about that, just using some pictures that we showed in terms of what is going on in our city. So this was a very interesting experience of the students. This is the vereador. This is a representative elected. This is one of the most highly elected by the population in the city. It's a very young lady. She has her master's degree in Barcelona, and so you guess which kind of party that she belongs. And this is the population describing things and all those talkings. Now we are planning this essay as a systematic social observation, a central square of the city. And we have some evaluation of the students. Of course, we have a lot of weaknesses. And it's interesting because they say about the division of content. Although we try to put together, they still feel that there is some division. But no, this is perhaps, I think this is very interesting. Perhaps the weakness of the discipline is also its great possibility and a fact of strength and charm to be unfinished with a body still information. I like that very much. And we have a diversity of topics. We are in itinerant class. We move around the university. We don't stay in one school. We go to other universities with the students and everybody. And we try to keep this eye on the interdisciplinary, which I think they evaluate as its strongest point. So those are the other ones, the strengths that they said, they comment, and that's it. We are trying to move towards a cutting edge pedagogy. I'm not sure where we're going, but at least we are trying. Thank you. I have a message, may I? This is a new journal. Tony Capon is an associate. And?
Tolu as well.
Yeah, right. Yeah, Tony as well. So The editor, his name is Marcus Grant, and he asked me to invite you because he's composing the review team of this new journal. It's a very interesting one, and so I'm doing my my lesson, inviting you to search in this internet, the website about this journal, which is very interesting. Thank you very much.
Do we have a question or two before we move to our last speaker? Okay, great. We'll have an opportunity to come back for discussion across the panel.
Okay. So I'm between you and lunch, so I understand that pressure, that responsibility. So luckily I've put together a very brief presentation. And the idea was really just to share with you some of our thinking around putting together, working on a curriculum around urban health. And when I say our, what I'm presenting is informed by two things. Firstly, over the last couple of years, we've been working towards setting up an urban health research network in Africa, so a regional network, understanding that it's obviously it's the most rapidly urbanizing region, or high up there anyway, but actually the capacity in terms of urban health research has been somewhat fragmented. So looking at a coordinated regional approach to build research on the continent. As we started that, we realized that, who's going to do the research, right? So if you don't have the capacity, who will do it? And I like what our colleague mentioned earlier about capacity building for beyond just the future generation, because on one hand we're talking about future generation, but who's going to teach it now if we're not learning now? So so that's one of the things. So a key part of that network, in addition to research, is looking at the education and training component, in addition, by the way, to looking at how we relate to policy at the regional, at the city, national and regional levels. So that's one thing. The other thing that informs this is a collaborative effort with some colleagues who are in the room here with the International Society of Urban Health, the education work group, my colleague Voinier, to look at really globally what is going on in the urban health training space and what are the gaps and how do we actually move forwards in that. So, okay, I think I might have spoken about this already. Okay, just to mention quickly in terms of the regional approach. So one of the things that we realized in starting to set up this research network at the regional level is what we should all know, which is that there's nothing new under the sun, that this has kind of come around, and that actually there had been previous efforts to set up not necessarily a network, but really looking at healthy cities and really pushing forward that initiative across the continent. And speaking to over the last, say, 30 years, and speaking to people who were involved, say, 30, 25 years ago, one of the key deficits in asking them, well, why was it was popular then, what happened? And one of the key deficits that kept coming up was really the capacity. So you have excitement, you have enthusiasm, best case scenario, and that gets things going, but actually keeping things going requires the capacity, and that is not just, from an academic perspective, but is not just at the academic level. And this is really the crux of this kind of transdisciplinary research, because if you don't have, if the only capacity you have lies in the academic, is still insufficient to have sustainable interventions. So just very briefly, this is, I think, is my only slide. I've just categorized some of the way that we're thinking, borrowing from the policy triangle. So those who work in health policy, we talk about
the context, the content, and the processes and the actors lie in the middle, and just kind of borrowing from that framework to think about some of the issues that we've come up with. So in the International Society for Urban Health, we ran a survey looking at different offerings that exist at the moment, so looking more in depth at about 20 or so offerings at the university level. And so some of the things I will touch on relate to some of what was found, and in general within each of the circles, as you go further down, it was more what wasn't there. So very commonly in terms of the content, i.e. the what. So when we talk about urban health training, what are we talking about? So very often in terms of the existing offerings, it relates to the built environment. So there's transport and urban design, green spaces, parks. When we talk about, so urban health, it's often urban and health, right? So you talk about the urban and then talk about the health, which is actually disease. But anyway, we talk about within these, they tend to relate more to non-communicable diseases, so and their risk factors. So whether that's obesity, physical activity, food, diabetes, that sort of thing. So that's one of the more common offerings across the board. The next kind of subset of offerings look more specifically at the urban almost as a disease reservoir, so looking at the vector-related and infectious diseases in the context of that environment and disease transmission. Just to mention that most of the offerings when in the context of health are anchored on specific diseases and much fewer on health creation and health promotion. So we talk about a disease and then because we try to simplify, right? But the focus on disease can be problematic in limiting our thinking. There's very little around equity, and this is very important because so I live in Cape Town, and whether or not it's called urban health, some of the interventions that really would be urban health, and you see them and you engage with them, this is fantastic, we're doing working wonders, or actually when you look at where they are and who's using them, they have, is the inverse, the Tudor heart, right, is the inverse of who needs, where the burden of disease lies, and where actually it's most needed, and where the bulk of the population in fact lies. So that equity approach is something that was missing. And the last thing, which wasn't really seen but was being mentioned today briefly, is considering the life course, that when we're talking about urban health, we're not just talking about the health of people now, but we're talking about the health, firstly, we're not just looking at the health of people now in the context of their current exposures, but that actually their health now is informed by their previous exposures. But secondly, that the exposures now also determine health of the next generation. So actually thinking about that intergenerational approach is something that we really have to have at the fore of our minds. Process, so in terms of the how, so this is some of the thinking about the skill sets. So some of the challenging things in dealing with interdisciplinary or transdisciplinary training is that, well, what skills are you can be talking across different things, but what are the skill sets that we're offering? So the most common was around the very classical epidemiology. Again, this is talking about what offerings already exist, classical epidemiological approaches. Next was around really looking at analysis of the neighborhood level effects and multi-level modeling. So those are the two most common in terms of the skills. The rest were much less common, so really community-based participatory research, and I think anyone who's tried to work in this space, as Sid mentioned earlier, understand that is really a fundamental component of urban health research. And really, and interrelatedly, the transdisciplinary methods, so looking at how to engage with multiple stakeholders and at what processes. So starting really from that kind of not just co-production actually, but before that the co-creation and engaging with the stakeholders before projects right through to co-dissemination. So again, it is not just co-creation and co-production and then we have to do something, but actually working out together what works best and disseminating that way. And putting that all broadly under the phrase of systems, that's ubiquitous systems thinking, but really looking at the moving parts within the urban system firstly, but also not just focused on the primacy of humans, but as Tony mentioned, but looking at considering the system beyond how it manifests within our bodies and our minds, as really important in terms of thinking about sustainable approaches to urban health. And lastly, in terms of the context, and this is, I think, is something very important to engage with because we talk about urban health, but really urban in very different contexts mean completely very different things. So really engaging with the different typologies of urbanization across the different globes. So we know that a lot of regions that are urbanizing now are not necessarily urbanizing according to the textbook presentation of what urban looks like. And related to that is engaging with the notion of informality and engaging with it beyond thinking about it in a unidirectional, it's informal now, yes, but how do we get it formal? And which is a very deficit-based model, actually looking at understanding that actually informality develops when a need is identified, right? And it's very, very adaptive, very resilient often, and it's not romanticizing it, but actually learning from it because it's constantly adapting. And I think that's important. The scale in terms of the time and the place, understanding the longitudinal approach to what has happened over time, which is what I mentioned in the African context. Importantly, the historical context of the urban space, because that informs how you think about what comes next. Because if you don't consider the historical, so in Cape Town, for example, we have the historical context of, one of the historical contexts of, say, the apartheid system. And if you don't engage with what the spatial inequities, which are very different in that context compared to another context that has spatial inequities, but with a different historical context, you lose the opportunity to actually better understand and inform your decisions going forwards. Links to global policy context has kind of been mentioned, so I don't want to touch on this. Mobility and migration I just want to touch on quickly because again, when we think about urbanization, and that links to the life course as well I wanted to mention, is that we can't not think about the rural. And this was something that was mentioned earlier because I use mobility because migration often, you think migration, you think rural to urban, finish. Whereas actually, certainly in a lot of settings, and in the African context, we know that migration is actually much more circular, much more dynamic. And so we can't really understand and impact sufficiently in the urban space if we don't understand the rural. You know, it's like trying to improve gender equity just by talking to women. You know, you have to get the full picture and everyone informed on board. And I think the last thing is around the actors, so who to engage with, and understanding that, you know, there's a diverse, I'm concerned about the time, so I'll move on to that. Okay, this is an example. This was just to remind me to mention that also when we think about training, we often separate that into research being a separate thing to training, and I just wanted to point out that also there's an opportunity in thinking about funding research to incorporate training, and this is an example of a research agenda that is funded through the International Council of Science and the International Social Science Council, where it's looking at transdisciplinary approaches to urban health, well, urban health being one of the themes, but importantly, incorporated in that is a capacity building component. So people are shortlisted and trained and then awarded. And actually, often we don't think about the opportunity to train as part of research funding. I'll leave this here because I've run out of time. Let's see, there's one thing. I'll just mention the last thing, which is the institutional context. So when we think about this is something that Willisca's just mentioned, this is something that we're grappling with. So in thinking about training, it's a make or break or make with great difficulty the institutional context of of setting up a training program that really cuts across different disciplines, and it's important to engage with that and to look for the best practice and shared learning. So talking to Tony earlier about what he's managed to do, get going to understand how to overcome those as best we can. So I think those are some key messages some reflections on urban health training that I've had. So do you have a question or two?
Yeah. So great talk and great. I love that the bubble. Very very useful to see how to frame urban health. Which is my question is. Maybe this is more of a general question, but from a training point of view, what is urban health? I mean, what is all of those things that you mentioned? It would seem to me that they apply to all ethics and to all public health and to all health in general. So what is different there? What is different in needing to use systems or to consider equity or the like, or the global policy context?
Yeah. So it's not I wouldn't focus on what's different. I mean, I prefaced that by saying that framework is borrowed from health systems, right? So, and I think, and this is the notion of transdisciplinarity, that is not necessarily focused on creating something entirely new that has not been done before, but it's actually using different approaches. So, but I think the focus is really what you're trying to do. It's a particular focus on the urban, firstly. And it is, okay, so maybe let me reflect on the personal. Let me reflect personally. So I think I probably spent most of my research career looking in the more traditional public health and epidemiology space, which for me was in the tuberculosis and HIV world. So it was very much around, okay, you have this disease burden. What angle do you want to take to look at whether it's from improving diagnosis, looking at risk factors to address, looking at the health system approaches, etc. So very traditional public health, very traditional epidemiology. Now, what moved me beyond that is the complexity. So what I realized in doing TB research day in, day out, is that when you get to a particular point in epidemiology, you realize that the things that you're throwing away because you can't measure and it doesn't fit into your logistic regression model are the very things that influence the outcome. But it's just, I'll just save that for the limitation section of my paper. when depending on whether I find statistical significance or not, and it really is, and that's what drove me to say, well, you know what? If I don't say my focus is TB, can I then engage with the complexity that is driving ill health? So that for me is a difference between a traditional, that's how it's played out. And I suspect it will play out differently in different people depending on your perspectives.
Good.
So thank you very much. So in listening to this last set of speakers, it struck me that one of the main things we need to do in training ourselves and training the next generation is to focus on flexibility. And so in that light, and in light of prior drills and other things that have adjusted our schedule, I'm going to keep my comments very brief and give us a few more minutes for a broader discussion. But what I did want to point to is, I think, the need that I keep hearing to complement more traditional research formats and more traditional, training in how to do rigorous research with innovative formats, with innovation in who's in the room, crossing some of the traditional disease-specific, discipline-specific, or sort of academy practice boundaries that we often have, and finding ways to then build the relationships and the clear messaging that are going to help us to bridge research and action, which I think is one of the values that we have together in urban health, because it's not only a matter of sort of what's our expertise, what's our set of skills, but also what do we hold as important. And I think some of the themes around equity, some of the things around, finding ways to get research into the right hands, finding ways to elevate the voices of community members are really core to what we have in common as a community, and what kind of gets to, I think, a bit of this comment about what's distinct about urban health. I think we don't want to only define urban health as being about cities or about urban settings and splitting cities from other kinds of contexts, but really, using the opportunities to inform action in cities to call into question some of the traditional ways that we think about health. Think about health not only of individuals and their organs, but of places and of the ecosystems that we're interdependent with. To think about equity not only by socioeconomic categories within a given place, but at a global scale, where are the actions taking place that impact health, and where are the benefits or harms from that being felt. So I think with that, I want to make sure we have a few more opportunities to hear from the audience, questions that could be for any of our panelists, and then in about 5 minutes we'll break for lunch and continue the conversation.
I really enjoyed this panel as I did the previous panel, and I was sitting here thinking that here we have this opportunity that's both local and global, and it seemed to me that all of your presentations were very much place-based, and they were very much place-based within a particular society. And that I'm wondering whether there are ways in innovative pedagogy to use the net, to do global classroom, or in some of these research projects, not just to look at urban, rural within India, but to look across, to understand the ways in which particular histories shape the relationship between rural and urban, and to how to take advantage of the theme of this conference from local to global in innovative ways, precisely along the lines that you're already developing. And I'm interested in how you might respond to that. So in sociology, there's an International Sociological Association, and when Michael Burraway was the president of the association, he literally developed an introductory sociology course where it was situated in one place, but there were people participating in that class from a number of different, in this case, university settings, so that there was cross-national dialogue, so that people from within a particular set of assumptions and frameworks were dialoguing with people also identified as sociologists, but with a different set of assumptions and frameworks. So as one is thinking about what is urban health, how do we teach it, how do we do research, to have somebody from Cape Town in dialogue with somebody from India in the classroom, in that global classroom, or in the research project. So it's kind of like pushing you in the direction that this symposium and the Welcome Grant are going, right? So.
Yeah, I think this is a very important point. Perhaps just briefly, in this context, I think we need to acknowledge that the Anglophone literature tends to dominate, but there's so much to learn across cultures, and I obviously this particular collaboration across Latin America and the Caribbean opens up dialogue across a number of other language groups, which is enormously important. And we also need to remember that there's lessons from Indigenous communities around living in perhaps not mega cities, of course, but living in urban settlements. I mean, I'm from New Zealand. Maori people have had Indigenous governance arrangements at the urban settlement level for centuries, and we can look at other Indigenous contexts as well. So there's lessons from North Africa about living in very hot climates. They didn't have air conditioning, but they still lived well in extreme heat, that we just switch on the air conditioner. So, there's a lot to be learnt and shared across different contexts and histories, as you say.
Hi, I'm Mary Bouchot from Thomas Jefferson University, and I teach in the BSN program. Thank you for starting that conversation. I'm sitting here thinking, every time I come to a symposium or I come to any conferences, I get so rejuvenated. You want to go back to academia, and I want to share so much. I want to add so much more to the classroom. I'm going to do all these innovative ideas. And as I was thinking, and your excitement of bringing in now the global into the classroom, and we redesigned the BSN curriculum, and now we're doing innovative things and making the student more responsible for their learning and engaging them more. But the bottom line is, you have that reality. The program now is, we're now getting the BSN student of a second degree out in 12 months. Boom, it's done. And in 12 months, I want to incorporate this. I want to teach about urban health. We got rid of our community class, and now we're integrating concepts of community and population health all throughout the curriculum. We've gotten rid of the PEDS course in the OB because we're integrating everything across the life care continuum. And I'm sitting there thinking, and now in the classroom, I'd like to engage and bring in, tell all the new words, in somebody from Africa to talk into the class with all of that. And right now, the student wants to know, what do I need to know for the test? Because I gotta get the heck out of here. I have another point. And so I think all these things are exciting, and I want to incorporate all of that as I can hear the enthusiasm and the talent of everybody in here. And somehow we also have to get that engagement and excitement in the classroom in a time frame that people want to get 17 degrees in 12 months. We want to hurry up and get out there to work, but we really didn't want to learn about all those things. And one of our new added commitment is cultural sensitivity and awareness. And so now faculty's getting trained to be culturally sensitive and aware and be able to teach about culture when it's the same people teaching about the culture who are not from any other culture. Do you know what I mean? So I guess I just want us to think about if we have a solution of how we can make the classroom more global, more exciting, but all in that time frame, which is very limited, and keep shooting it smaller and smaller.
This seems like a great topic to take up over lunch. I had seen Jabular's hand, so I want to give him an opportunity before we wrap up.
So I had a question for Dr. Oni. I was really struck by your career epiphany that as an epidemiologist you realized that the good stuff was not what you could include in your model. And I'm curious how you would advise us in training the next generation of epidemiologists to build that epiphany that you had into their training.
You can add epiphany to your.
I'm just going to say,
Epiphany 101.
that we have.
I think it boils down to the philosophy of what we're trying to do, and I think traditional epidemiology is so grounded in what we can measure in a particular way, and it's somehow, which is important, but at some point it's inverted into where the output is driving what we get, because we can measure and we keep it simple so that we can measure it, but then you can see where it started, and actually where we are now is that if we can't measure, we don't engage with that complexity, we just deal with what we can measure. So we're constantly dealing with a bunch of best case scenarios, proxies, but actually we don't actually know how well they represent what we're trying to look at. So I think it's really engaging with the messiness. Because actually one of the things I liked about epidemiology is how clean it can be. And I miss that some days.
because it's engaging with the messiness and embracing the messiness and not just looking for discrete things that you can then look at and then because then you end up speaking to the model and not to actually the population that you're trying to infer.
So I think on that note of complexity and the challenges that lie ahead of us, I want to just invite you to join us for an informal lunch and continue these conversations, and I look forward to seeing many of you over the next couple of days. Thank you.
I wanted you to say more.
You might be able to say a little more.